think like I would great in your last conducted the theory exam, and out of so many the examinees you all have cleared, and now you are in the final league of your DRNB and DM exam, and this will definitely fetch you the coveted position, the tagline, the CV, I would say ornamentation that you will be proud for your whole life. So something big for all of you, and we all celebrate your success in the theory exam. So congratulates from our all the top as well as the 360 critical care team to all the faculties who have taught you, who have taken some like of your like part of your journey. So though they are joining, like no, they will be joining in due course of our classes, online classes. But yes, now we are, Dr. Darshan is here, Dr. Niharika is here, and Darshan, anyone from our faculty team who are here in this?
The two of us, including you, sir. I
Yeah,
think so. I
perfect.
saw you.
So we have actually allocated our faculties into different days because it's a 4 day course. So definitely it will not be possible for all the faculties because it is the working hour also. But yes, we will be taking care of you for last like the next 4 days, and I am now handing over the session to Dr. Darshan, who will be taking you through the our proceedings, and also how we are going to conduct the online course, and also how it would be again beneficial to you. What are the prerequisites you should be following so that the benefits would be amplified, because it's a two-way process. We don't want you to all like not logging in, or like I would say keeping all the things later on to read, because it's now or never, because it's almost I would say 1 month and 15 days or less than that for your practical exam, and there are Christmas, New Year, and some or other holidays are there. So better you should sweat in peace rather than bleed in war. So that is my concluding statement. And I also thank Darshan as well as Niharika for sharing their knowledge, expertise, and despite their busy schedules, they have agreed to again share their expertise and the knowledge that they have gained in their training period as well as over last couple of years as working as a consultant to all of you. Thank you and best wishes.
Thank you, sir.
Thank you, sir. Thank you for letting us present each time, and thank you for the opportunity. And going ahead with the talk, I think so. I'm going to share my screen. Yes. Is my screen visible?
Yeah, Darshan.
Okay. Okay. So, firstly, again, I would like to congratulate all of you on clearing your theory exams. So it's like you have crossed many hurdles to reach till here. Probably you have one last one, and that's your practical. So I think so. This is not an important session if you see from the academic point of view, but this will definitely reduce some amount of anxiety. The whole thing about my 10-minute talk is just to get you oriented towards how an exam looks. Definitely, you guys have given your FAT exams, so you will know how an exam feel would be like. But theory in the is one game and practical is another. And when you're going to another setting, another hospital, probably in another city, the anxiety levels just shoot up. So the important thing is to keep calm as much as possible. So the outline of the talk would be what is the pattern of the exam, what's expected out of a candidate, and I will like to share a few sources which you can go and look up for your exam. You have quite a lot of time, frankly speaking. 1.5 months and more is actually a good time for you guys to, formulate your thoughts, practice, and then give your exams. So the conduct of the exam, usually you'll have two long cases, two short cases. You might have 4 or 5 stations, and then it will be followed by Viva. That again would be around 4 stations again. So the total marking of the exam is roughly around 300 marks, and the pass mark is 150. 150 is irrespective. It's not like an individually thing that you have to get 50% in each field. Like, for example, if it's 150 marks out of cases, you have to get 75, nothing like that. It's an overall assessment. If you get 150 and above, that is quite enough for you to have cleared the exam. But definitely, you guys have to aim more. That's the basic understanding of the mark allocation. So coming to the long case per se, long cases, usually major systems are the ones which will be given to you. Each one of you will be allotted a case early in the morning, probably 8:30 is where you have to reach the center. And major systems like CNS, RS, trauma, whatever is available, they will give you. They will give you a brief summary with all the relevant investigations, be it radiological, laboratory, okay, all of that would be given to you. So you can request. If you don't see anything, please request and please take it from the staff there. You'll have 30 long minutes. Okay, it seems quite less, but it is more than enough if you have a structured approach to the case. Okay, we will be going about how to go deal with the long cases and short cases in our practical course. The only thing I would say is have a structured approach. Don't get flustered. Don't get scared. All of us have this preconceived notion when we go to the bedside. Okay, this case is something that I was not expecting. Please go with an open mind. Do what you do regularly in your bedside. Probably that will reduce your anxiety level, that will help you focus on the case in the short given time, and probably you'll be able to pick up your answers. They will give you a booklet wherein you have to write a few salient points to just remember when the examiner asks you. Okay, it's not mandatory to write it like a theory exam, but few points have to be written down in the sheets. Okay, and after your 30 minutes time period, you will have your viva, which goes again for 30 minutes. The whole thing that the examiner focuses on a long case is your approach to the case, your correlation of data based on history, examination, investigation, focus, okay, narrowing down to a differential diagnosis and probably coming to a diagnosis as well. After you come to the diagnosis, they will go towards the management. And the management, if you have done well, excellent, they might ask you some evidence there. Okay, and in the meanwhile, definitely they will ask you to do some sort of an examination, be it CNS, RS, etc. Okay, so be ready for this. So whenever they do ask you to do an examination, be mindful of your surroundings. Always have your hand hygiene practices which you do daily. Usually because of the fear and the anxiety, you might miss it. So the examiner is going to look at all of these patterns. Probably then might not fail you, but few centers we don't know how the mood of the examiner is. So if you stay calm, the issues of making such minor errors would be very minimal. Okay, so based on all of this, how you drive the examiner, the questions would get changed. Okay, so by and large, do not utter something that you're not fully clear about. Okay, so focus on the case, answer to the case per se, and then probably if they ask you one or two things not pertaining to the case, that is good enough. Okay, so try and not dig your grave in the long cases. Okay, because it's 30 minutes viva. So the chances of you getting distracted and taken to another system altogether is very high. So be mindful of that. In short cases, it's very brief summary which will be given to you. Probably they will ask if it is probably with the CLD, they will tell you probably this patient has HRS. So focus on HRS. Okay, something like that. So you have to look at the data regarding that for diagnosis. You have to think about the management. Okay, and then you have to tell about the evidence. Probably they'll go over that. Okay, so you have to focused history taking. You have a focused problem at hand and how you deal with this problem. Okay, so that is what they usually focus in short cases. Again, here you will be given around 15 minutes time for prepping and 15 minutes viva. Okay, so you'll have two long cases and two short cases. So coming to the stations per se, you might have 4 to 5 stations depending on the center. That is not a fixed rule anywhere. Okay, but what usually the stations consist of is airway, ventilation, graphics, ABG, or basic data interpretation, imaging, CT, MRI, X-ray, that has to be included in one of the stations. This might be mixed with POCUS as well, or sometimes POCUS can be a separate station. ACLS is a mandatory thing for all intensivists. They will ask you the basic ECGs, hemodynamic monitoring, okay, and probably you guys have to buck up and go through the latest ACLS update as well. Drugs, instruments is mandatory. You will have at least 15 to 20 minutes of grilling in these stations. They are very vast. Okay, in the course as well, we will try to cover as much as possible, but it's humanly impossible to cover everything. But the whole idea of conducting these things is to give you a basic outline as to how to approach a case. Okay, so definitely you need to have a idea as to how an answer should be given. That is what we are focusing when we come to stations. Okay, coming to the Viva Voice, again, I told you they have 4 stations. Station 1 would be thesis. Okay, so thesis can be clubbed with your critical appraisal of research, or it can be a separate station. Usually, the center decides how they are going to divide it. Okay, so basically, in thesis, please know your thesis in and out very thoroughly. Okay, the statistical tools that you have used, what are the strengths of your study, what are the limitations, can it be used in the long run, or else they will ask you one important question: do you want to change any practice based on your thesis? Okay, so be ready for such questions. If your study is really wonderful, probably you can say yes boldly and substantiate why yes. Okay, so remember, this is a consultant level examination. You have your thoughts, substantiate and justify your thoughts. It will not be wrong. Okay, but don't argue. That is what I would like to say. Critical appraisal, you have a format, you have the pico format that you have to take in. Okay, then you have to know about your validity, your statistical tools, the strengths, limitations, etc. All of that would be required for you to look into. Usually what happens is you'll get around 5 to 10 minutes time when they give you the article. In that 5 to 10 minutes, you should use this format to come to a brief understanding of the article. Definitely the examiner will know that you would not have enough time to read the whole article word to word, page to page, correct? But the only thing is, if you follow these, probably you might find these answers which you're looking for immediately, underline them if possible, if they allow you to. Otherwise, keep it in your mind and you can answer them. Communication and ethics, there will be real life simulation scenarios which will be given to you. So sometimes it will be quite harrowing. People will literally bombard you with questions and they might harass you as well. But what they are looking at is how you deal with that particular situation. Okay, sometimes conflicts, we always think it's with the family. You might get a conflict with interdepartmental itself. Right now there's a lot of issue with such things. So all of this needs to be kept in mind. Breaking bad news is something that we as intensivists do on a routine basis. So all of this is something that they are going to look at during communication. Please know the latest ULC guidelines. Okay, you need to know declaration of brain death. That is, again, without say, that is something which is mandatory. Okay, coming to audit quality and safety, I need not tell you guys. You guys have had a very good exposure in your first paper itself, so you know most of the recent examiners are quite fascinated with audit and quality. So please know about all of them: antimicrobial stewardship, root cause analysis, quality indicators. All of them sounds to be not quite useful for you guys, but what you need to understand is you're getting your DRNB or DM, you're getting a consultant level examination. So you need to know management of ICUs as well. So that is one reason they have made that as a mandatory thing, that all of us have to know these things as well. Okay, so this is majorly about Viva. So per se, summarizing a whole thing, what is expected out of a candidate in a long case is you have to present it in a clear format. Okay, so don't be hesitant, don't give long pauses. So you have been given 30 minutes, so you have to write. If the examiner asks summarize the case, you have to be very quick and give a summary. Just don't tell a history of fever for 3 days followed by cough with expected. Don't go like that. Okay, please come to a crisp summary. Okay, and justify why you have come to that summary there. Always remember, you have to focus on the critical care aspects. Don't get sidelined with basic medicine. Okay, so the examiner is looking at that. Always look at the endobedogram. As soon as you get a case allotted, stand there for 1 minute and just look at the surroundings. Okay, look at your surroundings, know what the patient is on, whether the patient is ventilated, on sedatives, on paralytics, on vasopressors. Okay, what are the tubes and catheters in situ? All of them probably in 1 minute will help you focus towards a particular case system. Okay, so all of this is something that the examiner is also looking at, how well you have formulated your thoughts how well you have approached your case, and then come to a diagnosis. Always, when you're giving a diagnosis, start with the differential. Before you go to the differential, correlate all your things, that is, your history, examination, your investigations, be it radiological or laboratory, and then come to the differentials. Okay. So then, if you have a solid evidence that this is the diagnosis, please provide the diagnosis as well, because most of the centers, they want you to come to a diagnosis as well. Okay. So that is about long case. Short case, I told you earlier, short interest. The what they're looking at is how did you narrow down to the diagnosis and how do you manage. So majorly, they will either look at coming to the diagnosis or management, or sometimes if it's a very trivial case, probably they'll look into both of that. Basically, they want to know if you're practicing safe critical care or not in these cases. Okay, that is long and short. Remember, stations, Viva, everywhere, please don't argue with them. Okay, so that is the main important thing that I would like to tell you. It's a consultant level examination. Be confident, answer confidently. Okay, so maintain your basic etiquette. Okay, bedside manners. Please be thankful for the person who is helping you around, be it the sisters or any aides or even the expert examiner who comes across. Okay, it will come in handy somewhere. Okay, might be it is not generalizable, but at least will help you. Never bluff to the examiner. Okay, it's a very bad thing that if you bluff, and you might end up in a vicious spiral wherein you will dig your own grave. So please try and avoid that. If you have some educated guesses, if you are really good enough with that, then go ahead. But by and large, if you people are worried that you cannot bluff properly, please don't bluff. Okay, that is very important. Non-academic part is also very important. All of this is quite easy for me to tell you, but yeah, please dress formally. All of this is matters, how you present to the exam, how do you greet the patient and examiner. Okay, groom yourself well. Please get oriented to your exam center and venue a day before itself. Please go there and come. Okay, so that you don't have any jitteriness on the day of exam. Carry all necessary documents, be it your thesis, your hall ticket, etc. Okay, and remember, keep calm, and definitely you can conquer. Okay, that is nothing extra that I would like to tell, because you guys have given enough and more exams till now. This is not the first exam, or not for first practical guys are giving. So well, that I would like to tell, there are few sources for the theory. Whatever you have prepared, that is the best source. I wouldn't tell you to change anything. Definitely you guys have used your case-based review, your updates, but if you guys really want to read up about the recent updates, okay, please look at Nature reviews. They have very good things regarding critical care illnesses. ICU one pager is a really good resource. If you're traveling and you cannot carry books, please don't carry books to the exam center. That is really not necessary, because you don't have time. The only book that is required is your logbook and your thesis. Okay, and with a hall ticket. So one ICU one pager actually has a very good short summary of most of the issues in the ICU. That is one thing. If you are looking at research along with bottom line, there's something called as ICU Reach. Please look at that as well. There are many other resources like MCRIT, PalmCRIT, etc. But this is based on your ease and what you were following all of this while. Okay, so with this, I just want to say that hard work definitely pays, but smart work rewards you more. Okay, so all the best for your exams. And with this, we start off with the practical sessions. Firstly, we have a change in the agenda today, because Dr. Niharika will be starting first, and then Tapasya will take over. We have 4 days fixed, but if in case we feel that you guys need to be having some more time for any explanation, we will definitely get back to you and share you. The whole positive point that we got is, because it's in 3rd and 4th of February, we guys can reconnect in the meanwhile as well. So if you guys have anything to discuss or you need any help in between, please let us know. Okay, thank you.
Thanks, Darshan, for explaining the whole process of the exam, as well as also how to prepare in the upcoming maybe 30 days or so. And it's a proven fact that if somebody is going through this way, they would be definitely clearing. So the 0.0% is no, we all know nobody can give guarantee. But yes, the process is same, and you will remember all of us on your date of your exam, practical exam, when the examiner would be asking the similar type of questions in the similar fashion. And at the end, when you complete your exam and you come back to your home or your hotel, if you are appearing the exam in some other city, so you should be thankful. So yes, so Darshan, now the next would be Niharika.
Yes, sir. Yes, sir.
Okay, perfect. So now I am leaving from the hospital, so hopefully I will also join after Niharika will finish. Okay,
Sure,
thank
sir.
you.
Okay, sir. Thank you. I hope my screen is visible.
Yes, ma'am. It
Okay,
is.
Darshan. Thank you. So today we'll start our practical exams, but before that, I would request each and every one of you all to start presenting the cases. So you have more than a month time, okay, at least per week. Try to complete all the system. Short cases, long cases, hold your senior or hold your consultant. Please present it, because the way you present, the knowledge they share you, the questions they ask, they actually help you in your exam. Okay, so this batch is actually lucky because you have a time in between. Okay, so please start presenting the cases. So morning hours you will be with the cases. So if you answer confidently, it will boost up your session for the afternoon. Okay, so that is a request from my side. So not wasting much time. So we'll go to the first part, instruments. So I think most of you all have read for your theory, and all the instruments or whatever thing I discuss here, it's most of it theoretical only. So you might be knowing most of it. But when you pick an instrument, how to speak about it is very, very important. So I'm going to give you only that part of how to speak and what to tell. Okay. So most of the examiners will actually ask you to pick up a instrument and talk about it. So be sure that when you pick something, you know about it, and don't pick the most easiest thing which is kept over there. Okay, so there are so many instruments, more than 20, 25, 30 instruments over there. So at least be perfect with minimum of 15 to 20 instruments. Okay, and some of the examiners might ask you to pick a specific instruments, that's fine, but because you know something about that. Okay, so I'm sorry, I have around 160 slides, but as I'm telling, most of it you have read for theory. Okay, so the first slide would be what to tell when you pick up an instrument. Okay, at least this background, if you keep in your mind, then it would be easy to answer in the exam. So the first one is description of that instrument. So whatever you pick endotracheal tube, you pick your Gudel's airway, anything, laryngoscope, you first describe it. So what is that? Suppose if it is an endotracheal tube, what is it made up of? Okay, so what end? Patient end. Okay, ventilator end. Okay, what are the markings? What that indicate? So please describe the instrument first. Okay, and if suppose that instrument has any classifications, like if you have picked up igel, you want to tell this is a supraglottic airway. Okay, so try to tell a superficial classification of which it belongs to. First generation, if it is an igel, first generation, second generation, or third generation. So you need to tell what is the classification. Third is, after describe the instrument, tell the indications or uses of that instrument in the critical care. Then comes your contraindications, and if there are certain advantages and disadvantages or any precautions that has to be taken while using that instrument, you need to tell. And lastly, if you're going to tell about some trials, the examiner would be more happy. And when you tell this, be confident in telling. Okay, so this is how you speak about the instrument. Okay, so description is very, very important. And at the end, better to tell some trials if you know about that. Okay, so now first we'll start with oxygen delivery devices. Okay, so I think most of you all know about the classification, but this is just a revision for you all. So oxygen delivery system is basically, or devices has been divided into two things. One is the high flow systems and the second one is the low flow systems. So low flow systems are usually patient dependent. What is patient dependent? It depends upon the respiratory pattern and the respiratory rate of the patient. Okay, so it is patient dependent and it has a variable performance. Okay, example of this low flow systems are your nasal cannula, simple mask and your reservoir masks. Now coming to high flow systems. High flow systems, in contrast to your low flow systems, it has a fixed performance. Means if you are giving around 50% FiO2, it will deliver nearly 48 to 50% of that FiO2. So it has a fixed performance and it is patient independent. So it doesn't depend upon the state of the patient. Okay. So examples for this are your Venturi mask and your high flow nasal cannula. Now this is just a difference between the high flow and low flow devices. So low flow devices, as I told, it does not deliver a constant FiO2. So it is a variable performer. So the flow rates may vary from 5 to 15 liters per minute. And here usually there will be a mixture of oxygen plus room air. So your delivered FiO2 will not be the same as you're giving it. Okay. So why there is a varying of FiO2? So there would be a high FiO2 in shallow breathing because in shallow breathing there is less entrainment of room air. So if you're giving around 20% of FiO2, patient might get around 14 to 50%. But if you are breathing more, hypercapnic breathing, so more entrainment of room air is there. So if you're providing 20%, patient might get 8 to 10% of FiO2. So that's why it is patient dependent. Since the flows are very less, there is less generation of aerosols. And this low flow oxygen devices are basically used in mild to moderate hypoxic patients. Okay. Now coming to the high flow devices. So here you have usually a constant FiO2 is maintained and the flow rates are high here, around 30 to 60 liters per minute. Okay, and it delivers important controlled and predictable amount of FiO2. Since the flow rates are high here, automatically your aerosol generation will be high in these conditions. This is used mostly in moderate to severe hypoxemic patients. Okay, so this is the difference between low flow and high flow devices. So if they ask about Venturi mask, the examiner can ask the difference between low flow and high flow devices. Now we'll go to the low flow devices. So introduction I've actually told, so I don't want to go in detail about it. So can you people unmute and answer? I don't know whether that option is available here. Can you people unmute or you can put in the chat box if possible. So what does this cartoon showing or what is this? Okay, there are some answers coming in the chat box. Okay, this is very simple. This is nothing but a simple nasal cannula. So when you're going to pick the simple nasal cannula, how do I start the description? So keep in your mind. So I'm taking this nasal cannula. So how I have to describe? First is about description and classification. So okay, I'm going to describe it as, so this is a nasal cannula, which is a low flow system oxygen delivery device. So it has a simple plastic tubing with prongs, which and over the ear adjustment. So it is available in various sizes for adults, children and infants. And important thing is how much of flow rates you can provide with this nasal cannula. So the maximum flow rates is around 5 liters. More than 5 liters, you'll not be able to provide with this nasal cannula because it is less tolerant. Patient gets more complications if you increase the flow above this. Okay. And you have to remember one rule in case of nasal cannula, that is 1:4 rule. What is the 1:4 rule? For every 1 liter, okay, so the FiO2 increases by 2 to 4%. For example, if you're giving 1 liter through a nasal cannula, the maximum FiO2 that can be achieved is around 24%. Suppose if you're increasing it to 2 liters, you should add plus 4 to this. Okay, around 28 liters. 3 liters, 32% FiO2. 4 liters, 36%. 5 liters, 40. So 6 liters you can give, but as I told, it is not tolerant to the patient. So the maximum is 5 liters. So the maximum FiO2 that can be reached with a nasal cannula is around 40%. So this you need to remember. So for each oxygen delivery device, you need to know how much is the maximum FiO2 that can be given to the patient. Okay. So remember this 1:4 rule. Okay. So indications, yeah, this can be, so the second part is indications and contraindications. So as such contraindications, nothing. For indications, it is in mild to moderate hypoxemic patients. If you want to tell about the contraindications, it cannot be used to in moderate to severe cases. Next comes your advantages and disadvantages. So in advantages, it is usually inexpensive, well tolerated, comfortable. The most important one is you can keep it easy to drink and eat or speak. Okay, and this can be used in patients with long-term COPD patients, LTOT therapy. So nasal prongs can be used for that. Now coming to the disadvantages. As I told, if you increase the flow or you keep it for a longer time, patient can develop pressure sores inside the nose. There could be crusting of secretions, drying of mucosa, epistaxis, and around 80% of oxygen, it gets wasted during the expiration. Okay. So because you inhale it and you exhale it and the nasal prongs, I don't know how much of oxygen you might actually really get in. Okay. So some of the studies tell that only 20 to 25% of oxygen, it actually goes inside. Okay. And the prerequisites here is you have to place it correctly and there should be no nasal obstruction. Okay. So this was about our advantages, disadvantages. Any precautions required here? As such, nothing. And trials also, there are no much trials. So that's about the nasal cannula. So I hope that just keep in your mind that initial slide. Okay. And then you can explain about the instrument. Okay. Now this is I think most of y'all can identify it. So this is your simple face masks. So when you tell about the simple face mask, you have to describe the parts of the simple face mask. So the simple face mask, so it contains a metal piece which conforms to the shape of the nose. It has the exhalation ports, it has the straps, and it has a tubing which is necessary for your oxygen source. Okay, so this is how you describe the instrument first. Okay, so that is the same I have described here. It consists of a mask with two side ports. The side ports allows mixing of room air with oxygen that is supplied. And the mask enlarges the reservoir of oxygen by an additional 100 to 200 ml. So it acts, basically this mask basically acts as a reservoir of your oxygen. Okay. As I told, the maximum FiO2 that can be given with a simple face mask is around 60%. Okay. And the maximum flow rates which you can give with your nasal prongs is, they tell it is 8 liters. Okay. Still you can increase to 15 liters, but same, if you increase the flow, it causes discomfort to the patient. Okay. So, and the minimum flow rates which you can keep when you keep a simple face mask is, it should not be less than 5 liters, because if it is less than 5 liters, it causes accumulation of carbon dioxide. Okay. So minimum is 5, maximum 8 to 10 liters through the face mask. If not, please change it to a Venturi mask. Okay. So that is very, very important. So keep in mind the maximum flow, the maximum FiO2, you can just write in a paper that this is the maximum and this is the minimum flow rates and the FiO2 that can be provided by each oxygen delivery device. Okay. Same, coming to the advantages, disadvantages. Advantages, it is simple, lightweight, and it can be used with humidity. Whereas your disadvantages is, important is you need to remove it while speaking, eating, drinking, or any other things, vomiting. It might be uncomfortable for a facial burn or trauma. Application problem when NG is in situ, and lack of leak-proof borders. So there will be a mixture of your oxygen with the air. So here also the amount of FiO2 which you give to the patient is unpredictable. That is the variable performance of the device. Okay. The next one is important, the reservoir mask. Okay. So usually they're going to keep the NRBM mask, but you should basically know the difference between your partial rebreathing mask and your non-rebreathing mask. So in reservoir mask, we have two types, partial rebreathing, non-rebreathing. Can anyone tell me the difference between these two in the chat box? Difference between your NRBM and your partial rebreathing. One valve. Okay. 3 valves in MRBM. 3 valves. Okay. Okay. Yeah, I think those who have told it is 3 valves, yes, that's the right one. So just how to remember this? Okay. So just remember these two images. Okay. So in your partial rebreathing mask, you have 2 holes for your expired gas to go. Okay. Similarly, in the non-rebreathing mask, you have these 2 holes, but there is a flutter valve here. Okay, so this is a one-way valve. Okay, so 2 valves are present on the mask and 1 valve is present between the mask and your reservoir bag. So this is the expired gas valve, whereas this is the inspired gas one-way valve. Okay, so there are 3 valves in case of non-rebreathing masks, whereas in partial rebreathing masks, it is actually same as your normal simple face mask, but there is an additional reservoir bag, that's it. Okay, so here a lot of mixture can happen. From the environment, there is a mixture of the air which is present, and there could be mixture here, the exhaled gas and the inhaled gas. But the advantages in non-rebreathing, these are all one-way valve. Okay, so you're going to get a pure oxygen, high amount of concentrated oxygen to the patient. Okay, so this is the basic difference between your NRBM and partial rebreathing mask. Okay. So when partial rebreathing mask, some important things which you need to remember is, so the reservoir bag capacity, how many liters, okay? So it can fluctuate between 600 to 1000 ml depending upon the size of the mask and depending upon the companies also. Okay, so the reservoir bag has a capacity of 600 ml to 1 liter of reservoir capacity. Okay, and the flow ranges from 8 to 15 liters per minute, and the FiO2 can be between 60 to 80% if you apply the mask properly. Okay, and one more thing you need to remember is the minimum flow rate here. Okay, in a simple face mask, it is the 5 liters minimum flow rate. Here it is 8 liters. Okay, in order to remove your exhaled carbon dioxide and to refill your oxygen reservoir again with the fresh oxygen. Okay, so this much you remember in partial rebreathing mask. Next, NRBM. So as I told, nicely it's been shown here. So 2 expiratory valves, and here will be your inspiratory valve. So when you take it, you tell. So this is a mask. Okay, it's a oronasal face mask consisting of two expiratory valves. Okay, you have one inspiratory valve, you have a strap here, an oxygen tubing, and a oxygen reservoir bag. So describe the instrument first. Okay. So as I told, two valves on the side of the mask, they prevent entry of room air, but it allows exit of the exhaled gases. Whereas the third valve is between the reservoir bag and the mask, which prevents entry of exhaled gases into the bag. Okay, any malfunction of these valves may lead to carbon dioxide buildup and suffocation to the patient. Okay, and this is one of the low oxygen flow devices which provides the maximum FiO2. It is around 80 to 95%. And the flow rates, the maximum you can keep is 15 liters here. Okay, and the minimum is 8 to 10 liters. Okay. Now, advantages, disadvantages. So, advantages, yes, this can be used in some certain cases of moderate hypoxemic patients, and exhaled oxygen from the analytical dead space is conserved in these devices because of the reservoir bag that is present. Whereas the disadvantages is insufficient flow rates, as I told, may lead to rebreathing, claustrophobic, and because the flows here are on the higher side, it may cause drying and irritation of the eyes compared to your simple face mask. Okay, so this was about your low flow devices. Now coming to the high flow devices. So these high flow devices, as I told, they are basically generate large peak inspiratory flows, which are usually used in cases of moderate to severe hypoxemic patients. Okay. Now this is a very important thing. So everyone know this is a Venturi mask. So this will be kept. Simple face mask, prongs, and NRBM and Venturi masks. Okay, these will be kept on the table. So this is a Venturi mask. So there are two types of Venturi masks. Okay, I don't know. Initially they were using this, and now they have actually changed to these. So these are interchangeable Venturi masks. Okay, where you have a color coding. But now they are using something known as adjustable Venturi mask, where they have only two, a white and green color, and for a minimum flows you have one color, and for the maximum flows you have one color. Okay. So Venturi mask, it is also known as air entrainment mask. So what you need to remember here additionally, so you have described it. So same, it's a mask, it has some expiration holes here through which expiration happens, same strap, everything. So you can just describe, here your classification comes. So Venturi mask can be of two types, interchangeable and your adjustable Venturi mask. So this is about the description. Now additionally in this, okay, before going to the actual principle, we will discuss about the FiO2 and the flow rates that it can be generated. So the FiO2 which can be given by a Venturi mask ranges from 24% to 60%. If you see here, this is 24%, the blue one, whereas the green one is the 60% FiO2. Okay, and the flow rate accordingly ranges from 15 to 50 liters per minute. Okay, so I don't know whether you need to remember all this color coding at a present situation. So if you have time, if you can, so just please remember the color coding. Now next is your principle. So what is the principle upon which your Venturi mask functions? Okay, so everyone tells it's Bernoulli's principle. It's not actually the Bernoulli principle. It is a combination of two principles. Okay, it is a Venturi modification of the Bernoulli's principle. So Bernoulli's principle is basically about the fluid dynamics which is present. So the modification which is happening in the Venturi mask is your Venturi modification of the Bernoulli's principle. So what does that mean? So when they ask you what it is, so you need to explain it. What is that? So in this phenomena, what happens? The rapid velocity of gas, which is nothing but the oxygen. So you are providing some high flow oxygen here. So when this high flow oxygen, it moves through a restricted orifice. Okay, if in the Venturi mask, if it moves through a restricted orifice here, so what happens? Orifice, it produces a viscous shearing force which creates a decreased pressure gradient downstream. So you're giving a driving fluid or oxygen here. When it passes through a restricted orifice, the pressure downstream will be reduced. So when the pressure downstream is reduced, it tries to pull the air from the atmosphere, which is nothing but the entrained fluid B, and there will be a commixture of both of these. So this is a Venturi modification of the Bernoulli's principle. If you can explain, if they, most of them will not tell to explain, but at least you should tell this, this works with this principle. Okay, and the size of the constriction also is very, very important. Okay, smaller the orifice, greater the negative pressure generated. Hence, what happens? More amount of ambient air will be trapped inside the mask. So that time what happens? Your FiO2 will be lowered. So if you increase the flows, your FiO2 will be lowered because the pressure gradient will be, the difference will be increased in these people. Okay, so the orifice size is also important. Since you're providing a lot of fresh gas here, okay, the chances of rebreathing and the dead space in case of Venturi mask is very, very low compared to your NRBM or your partial rebreathing or other low flow devices. Okay, the classification I've already mentioned about it. Now coming to the advantages. So as we told that since it is a high flow device, it will generate a fixed or a precise FiO2 to the patient. Okay, and and these high flow devices, since we give so much of high flow, you should have some humid air that is to be provided to the patient. So chances of dryness of any of the mucous membranes is less with your Venturi mask. Disadvantages could be uncomfortable, skin irritation, and as we all know, it produces respiratory depression in COPD patients with high concentrations. Okay, so these are the disadvantages of Venturi mask. Okay, now can anyone tell me the full form of what is shown here? Artificial manual breathing unit. Okay. So AMBU, artificial manual breathing unit. Good. So you're taking AMBU in your hand. So you need to explain all these parts. Okay. So everything you need to know the parts of the AMBU. This is very, very important. You're using in and out day and night AMBU. So you need to know the full form properly and the parts of the AMBU. Okay. So you have a self-inflating bag. Okay. And you have two ends. One is the reservoir bag end and one is the patient end. So a face mask will be attached here and you have two valves near your patient end. So you have an expiratory valve and you have a PEEP valve, two valves here. Okay. Then comes your self-inflating bag and near the reservoir bag in between you have one is your oxygen inlet and the second one is your pressure release valves. Okay. Air inlet and pressure release valves are present in the reservoir side end. Okay. Two valves here, two valves here. Please remember the names. Okay. Expiratory valve and PEEP valve towards the patient end. Okay. And additionally, you have a pop-off valve also in between this. Okay. So three valves here. Expiratory, PEEP and POP. Okay. Patient end. Whereas air inlet and pressure release valves near the reservoir bag end. Okay. So if you tell that, they'll be most happy. Okay. So now coming to the description you have given for that, no classification as such. Then comes your indications. So what are the indications of the ambo bag? So first is administration of high flow oxygen. Second, it provides, since there is a PEEP valve, there is a provision of PEEP. It provides controlled ventilation situations, and it also helps in augmentation of your spontaneous ventilation. Okay, so these are the uses of your ambo bag. Now coming to the complications. Okay, so easy to hyperventilate patients and limited ability to gauge the tidal volumes which are present. We don't know what is the lung compliance of the patients, and you just bag. We don't know. Patient might even land up in pneumo or subcutaneous. We don't know subcutaneous emphysema if you just, because we don't know the exact lung compliance here. Poor seal, yes, is common if one hand grip is used. Gastric distension, aspiration, claustrophobia if the patient is conscious enough, and exhaled secretions and moistures can result in exhalation valve dysfunction, increasing resistance to the expiration. Okay, so these are the complications which are seen with ambo bag. Now, next one, this is very, very important. I think everyone know what this is. Okay. Now, can you tell me what this is and just mention in the chat box what are the parts of this instrument? I'll give you 2 minutes. Okay, try to give the full form of the instrument. So whenever you're telling about any instrument, don't tell it as HME filter, just expand it and tell us what it is. Ventilator side with 15 mm connector, patient side connector, heat and moisture exchanger. Okay. Moisture exchanger. Okay. So this is a heat and moisture exchanger filter, and important is the part. So it has so many parts. So when you're telling, please explain it. Okay, so you have two ends. One is the ventilator side end where it's connected to the ventilator circuit. One is the patient side. So the ventilator side connector could be the 22 female or 15 male. Okay, so you have a patient side connector, and whatever the white material which you are seeing here is a hydrophobic filter material. Okay, and the important thing, the one which is there with the cap, it is a capnograph port. Okay, so please mention that. Okay. So now, just before going to HME, you should know the type of humidifiers. Okay, so humidifiers are devices which add molecules of water to the gas. So whatever gas oxygen we provide, it is adding moisture to that oxygen. Okay, so there are two types of humidifiers. One is the active humidifier, the other one is a passive humidifier. So what do you mean by active humidifier? It means that the humidification is happening in the presence of some external sources. Okay, some external source is providing the heat and water that is required, or moisture that is required to the patient. Whereas passive humidifiers are those where patient's own body temperature and the hydration will take part in providing the humidification to the patient. Okay, so that's the difference between active and passive humidifiers. So our HME filter is a passive humidifier. Okay, so when you tell the description, you tell this is a passive humidifier and start describing this instrument. Okay, so this box is just for your information. So at different sites, what will be the humidity that is present in our body? That could be a relative and the absolute humidity. What you need to remember is in the trachea. Okay, so in the mid trachea, the relative humidity is nearly 100%, and your absolute humidity is around 36 to 40 mg per liter. And the temperature that is usually maintained is 31 to 35 degrees centigrade. Okay, need not to remember at nose, hypopharynx. Just at least remember in the mid-trachea what will be your relative humidity, because the guidelines tell that when you're using either active or passive humidification, you need to reach this amount. This is in a normal patient where you don't have an airway. Okay, so don't have an airway. So this is what is maintained in the normal person. But when you put a ventilator and all, so when you give a high flows, there will be dryness and all. So you need to maintain this much of humidification in the mid-trachea, right? So passive humidifier. So as I told, it is used to maintain proper temperature and humidity in the respiratory gases that are delivered to the patients. And the most commonly used is your HMEF. Okay, your heat and moisture exchanger filters. So you should remember the key features of a HME filter while describing this, or while telling the uses of the HME filter, you need to tell the uses. So it helps in moisture retention, it helps in heat exchange, it helps in filtration of contaminants, and the most important thing, it is single use, it is disposable, hence the risk of cross contamination is less. So these are the key features of your HME filter. If you just mention this, that's more than enough. Okay. So the bacterial and the viral filters which are usually present here, they have a very high efficiency, filtration efficiency. It is more than 99.9% efficient. Okay, so that is very, very important. And the most important thing is, where do you place this HME filter? This is a question they ask. Where do you place your active humidifier? Where do you place your passive humidifier? Where do you place your nebulizers? Okay, this you should remember and you should tell. This they will ask. Okay, so your HME filter, that is your passive humidifier, should be kept between the patient and your YPs. Okay, that is between the ETT and your YPs. Here is the place where you keep your HME filter. Okay, just imagine this diagram, then you'll be able to tell where exactly to keep. Okay, so in HME filter, you should know the uses very importantly and where do you place it. Okay, so what are the benefits of its advantages? Easy to use, light. Okay, it can retain their ability to humidify for up to around 4 days. Less cumbersome during transport, lower staff workload, lower costs, and decreases ventilator-acquired pneumonias because it has a filter. Now, mechanism of heating and humidification, most probably they won't ask, but you should know that usually the filter, I told you, the paper type thing which is present inside, so it contains hygroscopic salts of calcium chloride through which it maintains the humidity. If you remember this much, that's more than enough. Now, complications or disadvantages. So this I will tell you where exactly, but just for the theory purpose, I'll complete it. So it is inability to use with all patients, especially in those who have hemoptysis, tenacious secretions. So it will be blocked easily. So you can't use in these patients. Those patients who have increased airway resistant and increased dead space. Okay. It has potential for unrecognized airway obstruction if filter blocks, drying of secretions, and it is not appropriate for those patients who have large air leaks like your bronchopleural fistulas. Okay, so these are the places where you can't use your HME filter. So this was given by the American Association of Respiratory Society. So contraindications for HME filters. Okay, this is an old one, 2012, but nothing has been changed as such in 2023 guidelines also. So patients with thick or copious secretions, where there is loss in the expired tidal volume like long bronchopleural fistulas, patients who are managed with low tidal volumes like those in the ARDS, because it will increase the dead space, in difficult to wean patients and those with limited respiratory reserve, hypothermic patients, and in patients with high minute ventilation volumes. So in these patients, these are not absolute contraindications, but are relative contraindications for the use of HME. Okay, so these are the contraindications that you need to remember. Okay, so when you tell about HME filter, and if you tell this, the examiner will be impressed. Okay, so I have seen a lot in the guidelines. So when exactly to change the HME filter? Okay, so according to most of the guidelines, they didn't specify exactly we need to change it for 24 hours, but they tell that better to change it once in 24 hours. Or the easy answer would be when it is visibly clogged, or there is signs of excessive moisture buildup, or if the patient produces large amounts of secretions. So this is the time where your HME filter has to be changed. Okay. So now this is your active humidifier. Okay. So this is placed. So placement of this is also important. Okay. So this is an active humidifier. So active humidifiers, it act by allowing the air passage inside a heated water reservoir. So what I was telling is this is placed outside. So an external source is providing the heat and moisture for the patient. Now where this is placed, okay, the placement is totally different from that of your HME filter. Now where this is placed, now it is placed towards the ventilator. Your HME was towards the patient side, so this is towards the ventilator in the inspiratory limb. Okay, so this is the expiratory limb, this is the inspiratory limb, and it's proximal to your ventilator. So these devices are placed in the inspiratory limb of the ventilator circuit, proximal to the ventilator. Okay, so please remember the positions. Don't get confused. Okay. Now, types of active humidifiers, I think it's not necessary. As I told, the American Association of Respiratory Care in the recent guidelines have told that we need to maintain a temperature of 33 plus or minus 2 degrees centigrade with relative humidity of 100% and a water vapor level, that is your absolute humidity, of around 44 mg per liter. Okay, so that is usually done with your active humidifier. That is the thing that you have to be maintaining in your mid-trachea level. Okay. Now coming to the advantages and disadvantages of active humidifiers. Advantages, they do not have any contraindications as that of your HME filter, where your American Association of Respiratory Care has given certain contraindications. So as they are placed in the inspiratory limb, they do not add any instrumental dead space. So your dead space is also removed here. If used correctly, they do not increase the resistance also. And additionally, they have some alarm system. So if there is any obstruction also in any there, the alarm system will be activated. Okay, and they are more efficient to deliver the accurate temperatures and the humidity to the patient. Okay, coming to the disadvantages, since it has an electric thing that is attached to it, so it's based on electricity. So possibility of electrocution in the patient and the operator. They expose the airway lesion to excessive temperatures. Presence of water in the circuit can limit the airflow. Condensation can lead to ventilator asynchronous. Colonization of the circuit can happen, and they require more monitoring to ensure the correct performance. Right? Because there should be HME is just a use and single use thing, but this requires a lot of maintenance. Okay, so that is the disadvantages of using the active humidifiers. So this is one of the best way to remember where to use what. This is an older one. This was published in some 1999. But still, I think this is one of the best way to remember where to use your active and passive humidification. And at a present situation, we all feel that active humidification is a better one. So any patient who requires an artificial airway or a patient is on NIV, then first you need to evaluate all these things. Whether patient has abundant or bloody secretions, any thick secretions, patient's temperature, hypothermia is present or what, and whether patient requires a low tidal volume ventilation. If everything is yes, or any one of these is yes, then better to use your active humidification system. If any of these is no, then you can use your HME filter. So the older guidelines told that you can change one HME filter 96 hours or earlier, but now they have got it down to 24 hours for infection control. Okay. And those patients in whom you're changing your HME filter more than 4 times a day, then in such patients, the better option would be your active humidification system. Okay. Okay. So can anyone tell me the name of this instrument? Aerosol. Okay, very good. Ultrasonic nebulizer. Good. So I don't know how many of y'all are using this nebulizer. They could keep a normal routine nebulizer which we use, but most of the ventilators and many big hospitals where you go might keep any of these um, nebulizers. Okay. So what are those? I'll just let you know. So nebulizers. Okay, these are the devices which are used to transform your liquid formulations and suspensions into an aerosol form. So these devices can be used to deliver large volumes of a drug as an aerosol either intermittently or continuously for prophylaxis as well as treatment purposes. So depending upon the mechanism of operation, we have three types of nebulizers. So some use just nebulizers, some use ultrasonic, and rarely, and the best one to use is your vibrating mesh nebulizer. So I think most of your hospitals have a jet nebulizer, ultrasonic in some, but I think very rarely you get your vibrating mesh nebulizer. It is very costly. Okay. So the first one is your jet, ultrasonic, and your vibrating mesh. So this is just a simple table which gives information about all three nebulizers. Okay. So your jet nebulizer, so it basically the mechanism of action is the pressurized gas. It forms a jet which passes through your tube, creating a low pressure zone. Same your Venturi effect is seen with your jet nebulizers. But the droplet size that is generated here is more than 5 micrometer. Okay. So going into the smaller airways, the medication which you give is comparatively less with jet nebulizers. Okay. It is very cheap, easy to use, but the main disadvantage is it is ineffective. Okay. Now coming to the ultrasonic here. Okay. You use some piezoelectric crystals are present which helps to convert your electrical signals into your liquid form or the aerosol forms. And here the droplet size may vary. Sometimes it may even go less than 5 micrometer. Okay. So advantages, it is easy to use, more efficient than your jet nebulizer. Okay. And the disadvantages is it produces a large residual volume after the use. Okay. Oh, I don't know why all this is happening. Okay. Now coming to the best one is using your vibrating mesh. Okay, here the droplet size is very, very important. The droplet size is less than 5 micrometer. So it can go to the most smallest airways also. Okay, so the advantages is it is silent operation. So it won't cause a lot of sound as that of the jet or ultrasonic. Okay, it has a short treatment time. It has minimal residual volume after the completion of the treatment, but it is important disadvantages. It is more expensive. Okay. So that is about your different types of nebulizers. So what does the guideline tell? Okay. So during the mechanical ventilation, vibrating mesh nebulizer or your pressurized meter dose inhalers with spacers are recommended for aerosol delivery with no preference between the devices. Okay. And now, can anyone tell me, seeing this image, which is the best position for keeping the nebulizer? Either A, B, or C? Be fast in the chat box. C. C. Okay. B. Okay. Jogendra is telling B. So actually, this was one of the article, okay, which has actually placed these three in these positions and saw what is actually it was not statistically significant, but the amount of the salbutamol actually they gave the drug. So they saw that the best or amount of drug that is reached the serum levels they have seen is with the position B. Okay, so it is recommended to place the nebulizer in the inspiratory limb, that you need to remember, away from the Y-piece and towards the ventilator. Okay, if you keep here, it's okay, but you need to switch off your humidifier. Otherwise, all your drug will go into this humidifier. So A is not the ideal place, either B or C. But in this study, which I have taken from, they told B is the best position. Okay. So better you remember it is in the inspiratory limb towards the ventilator and away from the Y-piece. Okay. So in the nebulizers, they ask what are the drugs that you give. I think most of you all know. So you give bronchodilators, you give inhaled corticosteroids, combination of SABA and SAMA, mucolytics, and your antibiotics. Okay. So can anyone tell me what are the antibiotics that can be given in the inhaled route? In the chat box first. Antibiotics, Tobra, colistin, Tobra. Okay. Colistin, Vanco. Colistin and Tobra, Astrianum, aminoglycosides. Good. Okay. Cliomycin, I don't know, availability is also not so much. So at least you should tell about, yes, colistin, tobramycin, and amikacin. Okay. These three antibiotics you need to remember. And the dose of colistin is very, very important. So colistin is 1 million unit in a 10 ml vial. And tobramycin is 300 mg in 5 ml dilution. Okay. Okay. Now next comes this is all your theoretical part, so I don't want to go in detail about HFNC, NIV. Okay, it's been discussed in detail, I think, in the theory classes. So they might keep your HFNC just nasal cannula and tell what is this and may ask. So you need to tell the parts of your HFNC. So it has a air and oxygen blender, a heated humidifier, heated tubes, and a nasal cannula. Okay, so these are the four important parts of your HFNC machine. Okay, so the temperature fluctuations you can adjust from 32 to 37 degrees, and a humidity that is it provides is around 100% relative humidity, and the FiO2 can vary from 21% to 100%, and the flow rates are maximum is 60 liters. Okay. Now, important is they will ask you what are the physiological effects of HFNC. So these are all theoretical. Okay. So these are all theoretical questions. So I've just given it so that it's a revision for you all. So it helps in humidification of oxygen and improvement in mucociliary clearance, reduction of anatomical dead space, carbon dioxide washout, control in the fraction of FiO2. It reduces the work of breathing, provides some amount of PEEP. So what is the maximum PEEP that is provided with HFNC? 557. So for every 10 liters of the flow, you will get one PEEP, 1 centimeters of water of PEEP. Yeah, you're right. Sri Soumya is right. So maximum you will get is around 5 to 6. Okay, good. And that too, patient doesn't have a open mouth. So because the PEEP is lost over there. So with the closed mouth, for every 10 liters, it is 1 centimeters of PEEP. So what are the recommended flow rate and FiO2s? So in adults, up to 60 liters maximum, and FiO2, usually maximum you can give 60. Don't be happy by keeping it 80 or 100 and think that patient is fine. Okay. So what are the indications of HFNC? This is very, very important. Okay, the strong recommendation for HFNC is in hypoxemic respiratory failure. It has a moderate certainty of evidence. Okay, your conditional recommendations are post-extubation and post-operative HFNC in high-risk patients or those patients who are obese following a cardiac or thoracic surgery. And no recommendation is for peri-intubation period, but it has a modern certainty of evidence. Okay, so the indication, strong recommendation, hypoxemic respiratory failure. So other uses, okay, which has a low certainty of evidence, you can use it in acute cardiogenic pulmonary edema, sleep apnea, acute heart failure, do not intubate order, bronchoscopy, acute exacerbation of COPD, and other causes of hypercapnic respiratory failure where there is a contraindication to NIV. That is very, very important. Okay, where there is contraindication and a COPD patient, then you try to use your HFNC. So these are the other uses of HFNC. Okay, and everyone know how to predict HFNC failure. It is your ROX index. Okay, so actually recently I was just taking for some EDIC examinees, the ROX and all. So they might ask you to calculate the ROX index. Okay, so this patient is with this, please calculate the ROX index. So you need to remember the formula properly. What is the ROX index? Okay, it is SpO2 by FiO2 whole divided by your respiratory rate. And you need to remember all these values. I'm sorry, but yes, you need to remember this. Okay. So please remember the ROX index. Some examiners might even ask you to calculate it. Okay. Next, most of the trials, you know it. So when you tell about the HFNC, I told, yes, if you know the trials, please tell about the trials. Okay, so you have the Florali trial, you have the Florali 2 trial, OptiFlow trial. All these are for acute respiratory failure. Okay, you have the HEIGHT trial, which is for immunocompromised patients, but there was no mortality benefit of HFNC when compared to standard oxygen. And in post-operative period, the trial is Opera trial. Okay, so I've just given a gist of some important trials here. So just go through the trials, just mention it. Okay. Now this is the NIV mask. So this is also been covered in detail in theory. So the only thing is you should tell about the parts of your NIV mask. Okay. So where you keep it on the forehead, that is your forehead cushion, following which you have a forehead support. Okay. And this is the mask. And you have the exhalation system or the small holes here, exhalation ports. Okay. And this is the elbow. Okay. And this is the cushion mask which is present. And this, whatever you fix, this is the headgear. Okay. So please mention the parts of the NIV. Then what are the indications of the NIV, contraindications, advantages, disadvantages. This is how you tell about the NIV. Okay. So advantages, avoidance of endotracheal intubation, that is a main advantage. It preserves the airway defense mechanism, preserves the glottic function also. It improves patient comfort only in comparison with your endotracheal intubation. It preserves speech and decreased need for sedation. And the complications which are associated with tracheal intubations, those are all can be avoided with the NIV. Those are the advantages. Now coming to the physiology of the NIV, most probably you need not tell the physiology of NIV. So it is same. It helps in preserving the airway clearance, increases your functional residual capacity, decreases the need for sedation. Okay, decreases transmural pressures, pulmonary compliance is improved, and it augments your inspiratory tidal volumes. Most probably they won't ask about the physiology, but HFNC physiological benefits are very, very important. Now, indications. So there you came to know what are the indications. So here, the indications of the NIV can be divided into acute hypercapnic respiratory failure, which has a strong recommendation to be used here. The second is the acute hypoxemic respiratory failure and some special conditions. Okay, so please go through these indications. I don't want to go with each of it. I think the same thing I've taken from the theoretical slide only. So please go through it, but divide the indications. When you tell something, you tell with the evidence and divide it properly and then tell. Okay. Contraindications. Yes, a lot of contraindications for the NIV, especially if you're unable to protect your airways, especially in comatose patients, then NIV is contraindicated. Hemodynamic instability, inability to fix the interface, severe GI symptoms, massive hemoptysis, copious secretions, or in the post-cardiac arrest state. So you should know about all the different interfaces, okay, which you use, okay. So they might keep you usually the mask one, and if some uses helmet, so they might keep helmet. So you should know about it, the advantages and disadvantages of each of it. Okay, so the most common one which we use is the oronasal mask. So you should know about the advantages. So there are no mouth leaks, less patient cooperation required, and high ventilatory targets tolerated. Disadvantages, same. Skin breakdown, vomiting, aspiration, increases the space, claustrophobia, and gastric distension. The other one is nasal mask, which usually is used with the in home BiPAP, so you need not remember. And if possible, remember the helmet interface. Okay, so helmet interface, the advantages are less resistant to the flow. Okay, it also allows coughing, better comfort because there is no tight fixation, but claustrophobia is the most important disadvantage of this. Okay, so it is less interference with speech, no need of securing systems here. So skin damage is very less compared to your oronasal mask. Okay, and it can be applied. This is very important, regardless of your facial contour. Okay, so here you have to adjust the mask size, medium, small, large. Okay, so that's not necessary with the helmet. Okay, but yes, the greatest disadvantages is claustrophobia. Second, because this is a closed one, the chances of rebreathing and dead space is still high with helmet interface. Okay. Now, what does the guideline tell or the ISCCM recommendations? Okay, so which interface system is best for patients? So it is the oronasal mask. Okay, so it has a two-way recommendation. Whereas ISCCM tells whichever mask is chosen, a comfortable fit is of paramount importance. Care must be taken to use minimum strap tension that achieves an adequate air seal so that pressure sores are avoided. So whenever someone asks how tight it should be, you need to give the answer as this. Okay. And the need for excessive tightening is an indication that the mask is not of appropriate size or shape to the face. So don't try to use a medium mask for a small sized patient or for a large sized patient. Okay. And just keep on tightening it and patient is getting restless and you give some sedation. Okay. The other thing which they may ask is how to minimize the air leaks which are present. Okay, so one is the proper interface type and the size that is required. You should have a proper securing system. You should have mask which has a supporting ring, comfort flaps. The best way is what we have seen is hydrogel or foam seals, okay, which you apply it on the nose, okay. So the nasal bridge lacerations or contusions or everything will be uh, abrasions will be reduced with this hydrogel or foam seals, okay. Now, yes, how to predict NIV failure? It is the Hackor score. Okay. So HFNC failure, ROX index, NIV failure, Hackor score. You need to remember both of these. Okay. So Hackor is H for heart rate, A for acidosis, C for consciousness, O for oxygenation, and R for respiratory rate. Okay. So score of less than or equal to 5. So patient has low risk of NIV failure, but if the score is more than 5, then patient has high risk of NIV failure. Measure it 1 hour into the NIV and then decide whether you want to continue with the NIV or better to intubate the patient. So complications of NIV, as I told, a lot of things, disadvantages which I have mentioned. So at least 5 to 6 complications you need to tell within seconds. Okay. So gastric distension, vomiting, yes. Pressure ulcers, okay. Discomfort, inadequate ventilation, non-synchronous with NIV, mask leaks may cause air irritations, oral dryness. All these are the complications of NIV. Okay. Now next comes the tracheostomy tube. Okay. So I think a lot is there to tell. Okay. So can anyone explain the parts of the tracheostomy tube, please, fast? Okay, parts of tracheostomy. I will tell the trials for NIV later, okay? I'll just mention it. So tracheostomy tube. So this is the different parts of the tracheostomy tube. When you hold it, yes, so this is the flange. Most probably outer cannula. Some might have an inner cannula also. You have the inflation tube, pilot bulb, okay? And the important thing is your obturator. Okay, the purple color which is there, that is the obturator. So mention about the obturator, inner tube, outer tube, and that pilot bulb and all inflation tube that is present in your endotracheal tube. So that is nothing much. Only the flange will be extra. And the tracheostomy tie strings. Okay, so this is how you take the tracheostomy tube and explain about it. So you should know about the indications, advantages, disadvantages. So when is the tracheostomy tube indicated? Okay, one is for prolonged mechanical ventilation. Any cases of obstructive airways, like severe facial trauma, any tumors, or obstructions that may require a tracheostomy for easier airway management. In such cases, you require a tracheostomy tube. And third is the neurological conditions, like patient has a very bad head injury or severe stroke, MCA territory infarct, might require for a long-term ventilation. In such cases, neurological conditions, you might require tracheostomy. So advantages: improved comfort, enhanced airway clearance, easier weaning from ventilation, and increased patient mobility. Okay. So there are two types of tracheostomies. One is your surgical open tracheostomy, and the second one, which we do in the ICU, the percutaneous dilatational tracheostomy. You should know the steps of this. Okay. They will ask the steps of tracheostomy. So please tell it in a proper way. Now coming to the indications and contraindications. So rather than indications, I'll tell there are some important preoperative criteria for your percutaneous dilatational tracheostomy. One is patient should be able to hyperextend the neck. Okay. Second is at least 1 centimeter distance should be present between the cricoid cartilage and the suprasternal notch. And third is patient should tolerate, excuse me, the patient should tolerate transient hypercarbia and hypoxemia. So these are the 3 important preoperative criteria. Okay, indications I have already told. Contraindications, usually these are all relative contraindications. Okay, if it is an emergency airway access, you can't do a percutaneous dilatational tracheostomy, right? And if there is a difficult anatomy, or if there is an underlying coagulopathy, significant gas exchange problems, that is patient is in severe ARDS, you can't do a tracheostomy, or evidence of infection in the soft tissues of the neck at the insertion site. Okay, all these are the relative contraindications to your percutaneous dilatational tracheostomy. And the other thing is you should know the specific names. Okay, different techniques are there for percutaneous tracheostomy. So you should mention minimum 2, 3, at least 3 to 4 if you know. So the most common which we use is the blue rhino, Ciaglia blue rhino technique, or there is Ciaglia sequential dilator technique also, Griggs technique, Fantonis technique, and Frovas. Okay, so all these 5 names are there. At least remember 3. The most common is your Ciaglia blue rhino technique. The others you can just name. Okay. Now coming to the complications. These complications, yeah, whenever someone asks about complications, especially like endotracheal intubation or anything, you divide the complications like immediate complications, late complications, and immediate, early, and late complications. So immediate complications, that is on the table: hemorrhage, any damage to the trachea or the nerves or arteries which are present over there, failure of the procedure, loss of airway, hypoxemia, hypercarbia, all these are immediate complications. Early complications would be your hemorrhage, tube displacement, pneumothorax, subcutaneous emphysema, stomal infection, accidental decannulation. All these are our earlier complications. And later, especially your tracheal stenosis, tracheomalacia, and if you keep it long term, infections or fistulas. Okay, all these are late complications. Now, timing of tracheostomy. So this, okay, for my exam only they asked this. Okay, so they asked about the timing of tracheostomy. So what is the trial that's supposed to the timing of tracheostomy? There is no support as such for early tracheostomy. So the trial was your TrackMan trial. They asked me, what did they compare? 4 versus 10 days. Okay, so that also you need to remember. Okay, now one more trial which is basically in severe stroke patients, that is the set point 2 trial. Okay, they have compared 5 versus 10 days, and early tracheostomy did not improve the rate of survival. Okay, so 2 important trials for tracheostomy. Now there is, I think it's been discussed in detail about the decannulation of tracheostomy. So this is just a the brief one. I'm not discussing in detail. So your step 0 will be cuff deflation, followed by manual tube occlusion, followed by speaking valve. If they are tolerating for more than 12 hours, then you can do tube capping. If the tube capping is tolerated for more than 24 hours, then you can decannulate the patient. Okay. And just observe for around 96-hour period. If the patient is final, then you can tell it as a successful decannulation. If not, it is a failure of decannulation where you need to recannulate this patient. Okay. So there is no fixed method or steps of doing the decannulation. Okay. So this is one of the way of decannulating the patient. Now this is about the laryngoscopes. I don't want to discuss anything in detail about the laryngoscopes. You should know about the parts of laryngoscope. Okay, very, very important. Then comes the different types of laryngoscopes they might ask: Macintosh, Miller, and McCoy. Sizes you should know: 3 and 4, which we use for adults. Important for you is your video laryngoscopes. Okay, so video laryngoscopes could be non-channeled or channeled. In non-channeled, you have your GlideScope, McGrath, Storz, and the Kingvision. Whereas in your channel, you have your A-Track, Pentax, and the Kingvision could be either channeled or non-channeled. Okay, for channeling, you have a plastic thing that is provided there. So if you put it acts as a channeled video laryngoscope. So you should know about the indications, contraindications of endotracheal intubation, they will ask. Complications of endotracheal intubation. Here also you divide into immediate, early, and late complications. And what are the advantages of video laryngoscope over your normal, which I am not discussing in detail at all. Okay, these are very simple. You might have learned it in your anesthesia also. So next, so this is your bronchoscope. Okay, so you should know the parts of your bronchoscope. Okay, most of y'all are using it, but those who are not using, so you should identify what is a bronchoscope and you should know some parts of the bronchoscope. Okay, so this is where you hold it in your hand, where you have here a suction valve, and okay, through which a suction tube will be connected and you can do the suction. And whatever this is there, this is, you use a thumb here. So it is known as thumb control lever. for the tip motion. So if you want to move the tip here, you have to operate this. Okay. And this is the bending rubber tube which is present, and this is the insertion tube. And this is the working channel port. Here you connect the light source, fix it to there. Okay, so this is the parts of the bronchoscope. So you need to know the indications and contraindications of the bronchoscope. So indications of the bronchoscope can be divided into diagnostic and therapeutic indications. Okay, for diagnostic indications, to diagnose all, you take the ball and diagnose all of the bacterial, fungal, viral, everything. Any suspected foreign body is there or what, cause of hemoptysis, post-trauma to see if there is where is the site of trauma that has happened. Okay, in burn patients. Okay, so all these are your diagnostic indications. Now, therapeutic indications is very important. Removal of foreign bodies, mucus plugging and atelectasis to remove that, tumor debridement for airway obstruction, any stent placement, control of bleeding. Okay, some hemoptysis, where patient has a hemoptysis, you can control the bleeding by putting some endobronchial blockers, cryotherapy, or organ plasma coagulation. Okay, so all are these therapeutic indications of bronchoscopy. And the ATS, the American Thoracic Society, they recommend avoiding your bronchoscopy and BAL in those patients whose hypoxia cannot be corrected. That is, if their PaO2s are less than 75, okay, and if their PF ratios are less than 150, or if their SpO2s are less than 90, then better to avoid bronchoscopy and BAL in these patients. Okay, so basically it is severe ARDS, they are trying better to avoid it. And in case of, if you want to take a biopsy, transbronchial biopsy, it should be avoided if the patient has severe thrombocytopenia with a platelet count of less than 50,000, if their patient has an underlying coagulation disorder, or if there is a severe renal dysfunction, uremic bleed is more common in these patients. Okay, so these are the ATS guidelines which tell some contraindications to your bronchoscopy. So, and you need to remember what size of ET tube should be kept in order to do a bronchoscopy. Okay, if you're putting a 6 tube or 6.5 tube, and if you want to do a bronchoscopy, that's not possible. So when you introduce the bronchoscope into your endotracheal tube, it will nearly occupy 66% of the diameter of your endotracheal tube. So ideally, your endotracheal tube internal diameter, it should be at least 2 mm larger than the outer diameter of the bronchoscope. This you should remember. Okay, your endotracheal tube internal diameter should be at least 2 mm higher than the outer diameter of your bronchoscope. So ideally, they tell that the tube size should be more than or equal to 7.5 mm. 7.5 tube you should use. Okay, complications, hypoxemia, pneumothorax, bleeding, bronchospasm. Here also you can divide it as early and sometimes late. Okay, so this is nothing but your arterial transducer. Okay, arterial line transducer. So what they may ask, they may keep an arterial line transducer, and they may ask a lot of questions like what are the indications and contraindications of your arterial line. Okay, advantages, disadvantages. So I think most of you all know about all these things. So I've just put it in the box form. Okay, so indications for the arterial line, I've divided it as surgical indications, and medicine or patient related indications. Okay, or ICU related indications. So all these patient related comes into your ICU related indications. Patient on multiple inotropes, multi-organ failure, okay, unstable angina, recent MI, okay, if the patient is an IABP, okay, all these are the indications for arterial line. Surgical, the major surgeries which are present. So relative contraindications are your descending thoracic aneurysms, any local infection, coagulopathy, any proximal obstruction, your thoracic outlet obstruction or coarctation of aorta, or if the patient has a vaso-occlusive disease, then those are all the relative contraindications for your arterial line. Advantages, disadvantages, I think it's easy. So you should know, okay, the parts of it. Okay, so what does this arterial line pressure transducer has? The parts. Okay, so you have the main pressure transducer. Okay, then you have a three-way valve or a three-way tap, and proximally you have your fluid filled tubing. Okay, and towards the back you have a pressurized saline tubing and a cable to signal the processor. Now, important is what is the principle through which this arterial line measures your BP. It is the Wheatstone bridge. Okay, so Wheatstone bridge. So you need to know what is this Wheatstone bridge. I think most of you all know what is it. So basically, it finds this bridge is basically a diamond shaped um, bridge which is used to measure the resistance of the unknown side. Okay, so basically this, how does it work in your arterial line uh, pressure monitoring? So this arterial pressure from the catheter, okay, whatever catheter you insert, it is transmitted through your fluid filled tubing to a flexible diaphragm in the transducer. Attached to the diaphragm are something known as strain gauges. Okay, these are tiny resistors. So these are the resistors which is basically present. Okay, and these strain gauges are arranged in a Wheatstone bridge circuit. So whenever that pressure is transmitted here, okay, so the strain gauges, they stretch. Okay, and there is some changes in the resistance that is present in those small resistors, and that will produce a small voltage output, and that output is measured as your arterial pressure that is present. Okay, a little bit complicated, but okay, if you just tell about the Wheatstone bridge, that's more than enough. Okay, now you should know, why do you do zero? So zeroing and leveling are the two important things that you should know in the arterial line. Okay, so for a pressure transducer to read accurately, you should discount the atmospheric pressure. That is very, very important. So how to discount the atmospheric pressure from the pressure that you are measuring? By exposing this transducer to the atmospheric pressure and calibrating the pressure reading to zero. Okay, so that is about the zeroing. Why do you need zeroing is very important. Second, leveling. So when you are putting a radial arterial line, so at what level you should keep? So it should be set at the patient's heart level, that is fourth intercostal space in the mid-axillary line. Okay, so for every 10 centimeter up or down of this level, you will have an error of 7.4 mmHg. Okay, that is very important. This error, how much error, they might ask. So for every 10 centimeter error, it causes 7.4 mm error in pressure. Okay. Now you should know what is the normal pressure. They might tell you to draw it. Okay, please draw the normal arterial pressure waveform, and please you need to know how to draw it, and you need to name it. Okay, so what is a systolic upstroke? What is a pre-systolic pressure? Diacrotic notch. Okay, all these things you need to know. Okay. These are all not much important. And the other important thing which they tell, fast flush test. Okay, so when you're in the bedside, you're seeing one patient, when you're describing endobeddogram, yes, the patient has an arterial line. I don't know, the examiner might tell you to do a fast flush test and tell what you see in the monitor. Okay, so you should know how to do a fast flush test, please. Okay, go to the bedside, see how to do it. Okay, and you need to know how to interpret the fast flush test. So what is over damping and under damping, you should know. So when you do a fast flush test, ideally you should have a square wave pattern. Okay, so when you flush, there should be a square wave pattern followed by no more than 2 oscillations. Okay, that is a normal square wave test. What is over dampened? Okay, so you will have a square, but the thing is, you don't have the oscillations that are present. Okay, and the causes of over damping, they will ask you. So any obstruction in the line due to air bubbles, clots, kinking, or if there is low pressure in your flushing bag, or if the catheter diameter is very, very small, that will cause an overdamped arterial waveform. Similarly, underdamped, you have a lot of oscillations, more than 2 oscillations, which is usually seen in stiff tubing, catheter whip, tachycardia, and poorly secured catheter. Okay. So normal, you should know how to draw overdamped and underdamped. Okay, don't get confused between overdamped and underdamped. Okay. So next, I don't think that they are going to keep a pulmonary artery catheter. So it's already 6:20. I'll go through 10 more slides. Okay, till 100 slides, and tomorrow I think I'll continue the rest of it because it's too much. Okay. So coming to the pulmonary artery catheter. So most probably they might not keep this because now it's not, the use is absolute. So at least you should know the names of what are the ports that are used. Okay. So the important thing, the bigger one, just keep in mind, I kept in mind like that. So this is a bigger one. So it is a thermistor connector. Okay. Then after that, you have a little smaller one, which is also a thermistor connector, and this is used for your thermodilution measurements. For this is connected. Okay. So if there are two thermistor connectors, one is the basic one, which is a power plug for the heating filament, whereas the other one is for your thermodilution measurements. Then comes your PA distal lumen. Okay. Then you have this blue color one, okay, which is usually used for your continuous oximetry cable connector. Okay. Yellow one will be a distal tube, whereas your blue one will be a proximal tube. Okay. Through the proximal tube, you can inject your cold saline for your thermodilution measurements. And the last one, the smaller one, is your inflation of the balloon, which is usually red in color. Okay. So first finish off your bigger ones, then come to the 3 different colors, yellow, blue, and red. Okay. So yellow is your distal, blue is your proximal injector, and red is your balloon inflator. Okay. So you should know the distance, how to insert it. Okay. So I don't think that you need to know, but at least if you can't tell anything when they give PA catheters, at least when you describe it, try to tell what are the uses. So lots of uses of PA catheters was there. The first one is it guides fluid therapy and inotropic or vasopressor therapy. Second, it helps in the measurement of lot of hemodynamic indices. Okay, your CVP, PA pressures. Okay, and also helps to measure the oxygenation variables like what is the oxygen delivery, consumption, extraction, and what is the mixed venous oxygen saturation. It is also used for intracardiac ECG monitoring. It helps to measure the thermodilution cardiac output and also helps to calculate your lung water. And by gathering all this information, you will help to differentiate between a cardiogenic and non-cardiogenic pulmonary edema. Now, contraindications are very important. The absolute contraindications are anything related to your tricuspid and the pulmonary valves. So, tricuspid pulmonary valve prosthesis or tricuspid pulmonary valve endocarditis. Okay. And right heart mass. Okay. So, these are the absolute contraindications. Relative contraindications are your complete left bundle branch block, WPW syndrome, abstinence anomaly, any septicemias, or any hypercoagulable states. These are the relative contraindications. And you should know how the graft behaves at what part of the heart. So in RA, how will be the graph? RV, PA, and when you occlude it, your wedge pressures. Okay, and you should remember the pressures in each of these. Okay, in RA, what is the pressure? RV, PA pressures, and your occlusion pressure. Okay. So trials, there were 2 trials. which both of them proved that it doesn't have a mortality benefit. One is your Pac-Man trial. Okay, the other one is the escape trial. Basically, this escape trial, so what they have seen is PA guided, catheter guided therapy, whether it improved outcomes for severe heart failure patients compared to the clinical assessment alone. Okay, and they showed that PA catheters have no mortality benefit. So both of the trials showed that there is no mortality benefit. So this is about the CVC, okay, central venous catheter. So they might ask about your indications. Okay, I think most of you all know the indications. Then common sites of insertion. That's very, very important. So right IJV is the preferred site. Why? Because it is consistent, it has a predictable anatomy, it aligns with your right atrium. Okay, it is palpable landmark and it has a high success rate. Okay, and it has valveless course to the right atrium. So these are all the reasons why you prefer a right IJV. And where should be your tip located? That is very, very important. Ideally, it should be in your SVC, that is SVC RA junction. Okay, that is the ideal position where your tip has to be placed. Okay, and in the radiology, they will let you know exactly to see how whether your tip is in position or not. Okay, so you should know the anatomy, ultrasound guided or your anatomical blind technique. You should know how to do it. They will ask the procedure. That's very, very important. Then comes your complications. So complications, as I told, it can be divided as immediate, late. Okay. So I think we will stop here. And from the spine and needles, I think I will take in the tomorrow's class because there are still, I think, around 50 slides remaining. So next there is about prescription of CRRT and all. So we should go a little slow about that. So I think we will start with the spine and needles in tomorrow's class. I think we now will continue with Tapas sir's class. Okay. Now, whatever we discussed, if you have any doubts, you can, I think some of you all have put it in the group. I will answer to this. And any other things, please put it in the group. I will answer in the group, okay? In the chat box. Tapas sir?
Yes, yes,
Okay, sir.
yes,
I'll continue it later, sir, because it's too much actually.
yes. So whole critical care of 3 years duration we are covering in maybe 4 evenings, and that also again 3 to 4 hours. So it will be definitely difficult. But yes, if you all want to share any feedback till now, you have any queries, you can post in the chat box. So I have many things tonight because I will be presenting today only. So tell me, do you want right now the short cases first or the other topics? Like I have two more additions to my assigned topics. So I would be talking about brain death and organ donation because that is one major part of any clinical case as well as also grand viva. The second one I would be also talking about is auditing, counseling and communication. That is again one of the most important thing, and also the root cause analysis, short cases. Perfect. Okay, perfect. So I got already feedback from all of you. So just give me a sec. Mm, mm. Okay. Is my screen visible?
Yeah, sir. Visible, sir.
Okay. Somebody has posted brain dead organ donation communication first, but I think let's start with a short case because already Dr. Niharika has discussed about table viva. So just for a sake of change, I think let's go with a clinical case first. Maybe we can stop in between finish up the counseling, communication, organ donation, and again at the end we can go ahead with the second short case. Okay. Now, before going ahead, short cases would be almost Niharika, how many marks would be there for the short cases? Niharika, are you there? Okay, I think she has left. No problem. So there would be two short cases, and depending on the center, they may choose what would be the short cases, and again the marks. I think they would be sharing with you from the very beginning. But before going ahead, I want all of you to please focus on these two next slides. There are 10 golden tips for the short cases. I would be giving you many clues that would be helping you to crack the short cases uh, table. Start with always a one line problem representation like age, key diagnosis, organ failure, and current support. You are not talking about a medicine case, you are not talking about a surgical case, you are not talking about anything which will be a single system. So, a clinical pearl for all of you that you should be always starting with one line problem representation because this is a short case. This is not a long case. So this is a 56-year-old male with septic shock, ARDS on invasive ventilation and AKI on CRRT. So maybe they would be trying to examine or they would be expecting you to discuss about CRRT. So the CRRT would be your short case link. So, but yes, when you are talking about it, the clarity and confidence with which you start with the opening statement gives you the edge. So in the practical or in the exit exam, it's all about how you are actually answering confidently and in short time. So that is the whole essence. So that's why always start with a problem representation. So ICU awareness, not word thinking. Like always in ICU, we would be dealing with mainly ventilation, ABC, vasopressors, in this case, particularly RRT, and also when the patient is on ARDS and invasive ventilation, definitely so many devices would be there. In short cases, avoid long history because the time is very important. In short cases, they would be expecting you to at least examine initially, then go ahead with a short history and examination, and also after that, they're expecting to have at least 10 minutes of time where they would be also asking you some questions and you are also answering back. And from those answers, they would be also taking you to some other questions. So it is not a defined set of questions like edict 2. Are you clear? Or in the IFCCM also, so they have a defined question, IDCCM. Here, the examinees can take the questions to the the desired the orientation. So always it's sometimes not to be, I would say, in the smarter way, but yes, you can also lead the examiners to at least enter into some of the domains where you are very confident, right? Examination must be focused, not exhaustive. Sometimes I have seen that the candidate takes a lot of time in actually examining in detail. I would say in one way you are actually killing time and the examiner is actually trying to finish the short cases and again go for the other candidate short cases or long cases. So they don't have time. Try to feel that you are somebody who is expected to take almost 7 8 candidates examination in one day with long cases, short cases, table vivas, grand viva, checking the thesis, and again at the end maybe they would be leaving for the their work and they would be leaving the station. So you have to be very thorough what you are actually expected to answer in the real exam. So examine only the relevant systems. Like say you are looking for while examining, I am examining the chest or the respiratory system to assess ventilatory synchrony and complication. Maybe the question here would be, or the short case would be difficult in winning. So Rather, the examiner will definitely guess that you are actually knowing about that this patient is not ventilating in a proper way. There is some dysynchrony happening between the patient and the ventilator. And the complications are also, you are trying to say that maybe some diaphragmatic dysfunction element is there, maybe the patient is nutritionally depleted, maybe the patient is not ready to be weaned off at this point of time. So this has to be very clear when you are actually speaking. Speak in different headings. The examiner loves structure. I would now recommend that start talking in some of the technical terms the examiner loves to get into their brain. Use verbal signposting. Are you getting what is the meaning of signposting? Rather than using the similar words, this is for high scoring. This is for high scoring and also get good impression. My findings are, my interpretation is, my concerns at this point of time, my plan for the today would be. So this is something, if you are content in the average, but by the way you are speaking, the examiner would be little bit like, if I am the examiner, I would be also checking how confident you are in managing this patient. And by talking these lines, I can guess that this candidate has actually really worked in their ICU in the hospital for last 3 years, and he has seen the patient. Maybe he is or she is not dealing with so many advanced things, but yes, he or she is very confident in managing. Clear? Always add a bedside interpretation. Just don't describe so many signs or some of the syndromes. No, you have to always conclude with one interpretation, like raised JVP with hypotension. If somebody is trying to mention about the cardiogenic shock or obstructive shock, so you can always say raised JVP with hypotension suggesting obstructive or cardiogenic component. Right? Now, mention one key differential. Just like don't vomit all the differentials that can happen. The examiner would not be in that stage to get 10 differential diagnoses just like written in the Harrison's. No. Overlisting differential is a common mistake. The examiner feels that this candidate is trying to put everything into the basket so that maybe he or she can post in the goalpost. So that is not an ideal thing. Give 1 to 2, maybe maximum 3, most likely, and justify briefly. Just don't put it, and the examiner would think why he is saying about this differential diagnosis. Link findings to immediate risk. Examiner always wants to know that is the patient safe. So always maybe in your script when you are actually talking, my immediate concern is impending ventilator failure due to poor synchrony. Something you should be always mentioning. Now, in the management, it should be priority based. We are acute medicine specialist. We are not the regular medicine specialist or somebody from the surgery. So it should not be just from the textbook. You use the sequence immediate, next few hours, definitive, and avoid drug supping lists. That whatever drugs that is written in the book, you are trying to say. No, it would be immediate anti-hyperkalemic measure. If the patient is not responding to the immediate anti-hyperkalemic measures, I would definitely go ahead with the renal replacement therapy. So this should be the way forward. It should not be just like you will be mentioning about everything that is written in the book without a structured approach. The examiner always wants, or they feel good when you answer in a structured approach. Use ICU language. They don't prefer that you are using somebody who is a lay person, because you are a trainee, you are going to be a consultant, and you have already worked for 3 years in your ICU, and you should be using something which are technically right, medically sound, and in ICU specific context. So titrate, trained, de-escalate, escalate, small aliquots, assessing the response, always these things. Preferably use vague words like give, do, start something. These are something which will not be very impressive. Now I am trying to train you from now onwards so that you have 1 month. So try to at least answer in these lines. Clear? Now, last, always, maybe preferably, very high scoring, end with a safety statement. I would reassess clinically and objectively within the next 30 to 60 minutes. Something like that. So the examiner would feel that this doctor keeps the safety element of paramount importance. Clear? Okay. Now, common examiner traps: jumping to the diagnosis before examination, forgetting current ICU supports, overconfident, sometimes very gadget would be you can mention about so many gadgets, but very unsafe plans, and not reassessing or monitoring, because ICU is a dynamic place. You cannot expect that the things should be happening as per your first assessment and that would be your last assessment. No, the examiners are assessing whether they can trust you alone in an ICU at 2 a.m. This is something in their mind. Always, always. In the EDIC exam also, in ISCCM exam also, and also in DRNB and DM. So keep all these things in your mind. You will be also feeling very confident when you are answering. Now let's start with a case vignette. I'm just keeping this as a short case vignettes, because these are the theories we have already discussed. You have already cleared the theory paper. So I would not be going into detail of the theory, rather how you are actually expected to answer. That is the whole essence of this practical crash exam. I think I am hitting the target by this. A 25-year-old male, so I would be faster in discussing or the cases, because this would be taking a lot of time. We have a lot of presentations in my assignment. A 25-year-old male motorbike rider was brought to the ICU following a head-on collision with a car while traveling on a motorway. On arrival, he was found to have blood oozing out of his external auditory meatus and nostrils. Neurologic assessment revealed Glasgow Coma Scale GCS of 2T, E1, VT, M1. Pupils equal 3 millimeter bilaterally and not reacting to light. If somebody is writing something, okay, no, perfect. Okay, and not reacting to light. Family and colleagues questioned whether he was brain dead. Now, this was the short case to you. So, examiner would be always expecting you to at least go for the brain dead examination and also management. So, this is something a very pet question. This can be also asked in the grand viva also, in some or other tables also, difficult counseling also, and also long case. But I have kept it in short case. Now, how you will be approaching? Step one. The theory part you have already read, and I think there was a question also in your theory paper. So establish the underlying cause for the coma. This would be your first step. They would be expecting that you should be confident in knowing that what is the underlying cause for the coma. Never consider the diagnosis of brainstem death without a potential cause for the brain death or brain damage. The potential cause for brain damage in my case is road traffic accident and head injury, as the scenario has been given. Now, a search for the confounders that could mimic brainstem death should be made systematically before considering the tests to evaluate the brainstem function. Now, how we will be approaching? If there would be the pathology and you are expected to answer traumatic brain injury, duration of observation at least minimum 6 hours, spontaneous intracerebral bleed more than 6 hours, major neurosurgery, aneurysmal bleed more than 4 hours. So you should be observing. Then only you are expected to say that maybe this patient is not showing the neurologic improvement. Hypoxic brain injury from the cardiac arrest and drowning more than 24 hours, and any cause for the brain dysfunction with suspicion of drug intoxication more than 50 to 100 hours. So you will be taking lot of time, because the reason behind is the drug will be taking minimum 5 half-lives to be excreted from the body. So that's why it would be minimum 4 days, if you can just roughly keep in your mind. Clear? Now, step 3 would be, what are the confounders that could mimic? This would be spontaneous answers, because you have dealt with this question for your theory, in your FAT exam, also in your ISO practice. So look for the confounders that could mimic brainstem death before proceeding for brain death verification. Now, this should be examiner's pet question. So you should not be taking much time to answer it, or you are thinking. So you are actually killing your time and you are losing the further questions. Complicating medical conditions like several electrolyte abnormalities, hypoglycemia, acid-base abnormalities, severe hypothermia, severe hypotension, drug intoxication, including alcohol, poisoning, recent use of sedation or neuromuscular blocking agent. Now, if any of the confounders are present, the examiner may ask you, is it can I go ahead with the brain death declaration or not? So the answer should be, if any of the confounders are present, they need to be corrected and we have to observe for some time. Then only we'll again reassess the patient for brain death declaration. Right? So it's not that you cannot do the brain death declaration if some of the confounders are there. And in case of suspected poisoning, this is one example you should remember. An extended observation period is needed before proceeding to the further test. Now, what are the clinical conditions that can mimic brain death? So there are two different questions here. One is the confounders, one is the mimic. So similar thing that would be like presented as this patient is brain dead. One is high spinal cord injury, fulminant GBS, baclofen toxicity, organophosphorus toxicity, delayed neuromuscular blocker clearance, profound hypothermia. Clear? So this is something you need to remember. The questions should be coming instantly. So you should be very clear that these are the questions expected in my brain death short case. And after 3 years of extensive reading, again you have read for your theory exam, and now after attending our crash course, it should be in tip of your tongue. Now step 4, how would you proceed to identify brain death by complete neurologic examination? This would be a favorite pet question. First would be documentation of coma, and that is absence of motor response to a standardized painful stimulus applied along a cranial nerve path. Now they would be expecting you to do it at the bedside. Maybe they will not give it if the patient is not brain dead. You should not be pressing on supraorbital group or temporomandibular joint or trapezius squeeze. But yes, they would be asking you to show it in the patient, because the patient will have pain if the patient is not brain dead, and they will not allow the serious patients to be in your exam. Okay. Now, so where you have to do, you can just remember it, pressing on the supraorbital groove, temporomandibular joint and trapezius squeeze. Beware of the local spinal reflexes that can cause spontaneous or stimulus related motor movements. So you can mention this while you are actually checking or you are answering, so that the examiner would be clear that yes, you know that there can be also some false local spinal reflexes. Now, second one would be documentation of the absence of brainstem reflexes. I'm not going to read everything, but yes, as the brain death occurs, reflexes are lost in a rostral to the caudal direction, with the reflexes in the medulla oblongata being the last to cease. This is something you should remember. So rostral to the caudal direction, with the medulla oblongata, which would be the last, the part of the brain, the reflexes would be lost. Now, what are the reflexes you would be checking, or the examiner expect you to answer? Absent pupillary reflex. That would be checking the cranial nerves 2 and 3. Oculocephalic movement, doll's eye reflex, very important. You should not be confused at the bedside. That will be absent. So normally, this is one reflex which is normally present. Remember, they would try to confuse you. Normally, if some reflex abnormal, reflexes are abnormal, people say in a patient, but this is one reflex which is normally present, and if it is absent, then that would be hinting you towards the brain death. Okay, and before doing that, always check the integrity of the cervical spine. In heat of the moment, the candidates, they don't follow that, yes, this patient is having a neck collar, and you try to do the oculocephalic movement or doll's eye reflex. No, the examiner would be very irritated that you are actually trying to harm the patient just for the sake of your exam, and you don't know that cervical spine integrity has to be first checked or confirmed. You can ask the nurse or you can ask the doctor there that is there anything with the cervical spine before excluded, then only you can proceed with the oculocephalic movement. Now, I know you all understand what is the the process or the procedure to do the doll's eye reflex. I am not going to detail. This would take a lot of time. Okay. So Niharika is answering. So I thought you are posting some questions. Now, oculovestibular reflex is cold caloric test. Again, the process, the procedure, you should be very clear. One important thing, if there is blood in the ear, so you cannot do the oculovestibular reflex, or it can come inconclusive or negative also, or the ear is filled with cerumen. So that can diminish this response even in the absence of brain death. So you have to be very particular that the ear canal is actually clear. Now, absence of provoked tonic eye movement toward the side of the cold stimulus and absence of horizontal nystagmus towards the contralateral side indicates brainstem dysfunction. And this test checks the cranial nerve 8, 3, and 6. Now, corneal reflex, this is checked by installing few drops of the sterile saline over the cornea. And if absent, it indicates brainstem dysfunction. This tests the cranial nerve 5 and 7. Now, cough reflex. This is best tested by passing a suction catheter through the endotracheal tube, and when absent, it indicates brainstem dysfunction. And this tests the cranial nerve 9 and 10. So these are very practical reflexes that you can immediately check in the bedside also, and the examiner loves to hear from you about these very practical and standard brainstem reflexes. Now, the third point would be the apnea test. I'm again not going into detail. Prerequisites you have to remember. The preparation also you all know. Arterial line, beneficial, these are all the things the examiner expects you to know. Then conduction, how you are going to do the apnea test, when you will be drawing the ABG, what are the monitoring that you will be doing during conducting this apnea test, and what will be the conclusion. Now, PaCO2 more than 60 millimeter or 20 millimeter mercury above baseline, apnea test is positive. Now, if the PaCO2 has not reached the threshold and patient is stable, then continue apnea test and assess further ABGs until the threshold reached. Now, about the apnea test, if your oxygen saturation falls to or below 85% for more than 30 seconds, and maybe about apnea testing if your blood pressure is dropping rapidly. Clear? So something which you all know, but in the examination there should not be any ifs and buts related to this test. Now, step 5, any ancillary confirmatory tests you know, the examiner may ask you. Now, cerebral angiography, conventional. I am again not going into detail, but yes, there are certain things you should be remembering. Angiography of both the anterior and posterior circulation has to be carried out, and absence of the contrast flow into the intracerebral portion of the carotid and vertebral artery at the level of their entry into the skull is taken as a sign of brain death. That means it is not entering into the skull. External carotid circulation also should be patent. Delayed filling of the superior longitudinal sinus may be seen, and the limitation of the test is the need for transporting the patient to your angiography suite. Now, electroencephalography, EEG, complete absence of the electroencephalographic activity to intense somatosensory and audiovisual stimulation is taken as a sign of brain death. It is important to ensure that EEG recordings are done in a standardized manner. Limitations are the artifacts leading to the EEG pattern for false negative brain death diagnosis. Transcranial Doppler, again, lack of diastolic or reverberating flow. This is the classical TCD finding. and documentation of the small systolic peaks in the early systole. You should be only remembering these one-liners. The examiner would not be expecting you to go into detail of the TCD or EEG or cerebral angiography. Now, this is something I have already told you. Complete absence of flow in the TCD may not be reliable owing to inadequate transtemporal windows. That means you are actually not getting the perfect window. This is one of the confounder. Again, need for expertise and appropriate interpretation of the flow are the limitation. Now, cerebral scintigraphy, where you are not getting any cerebral blood flow, if you are using technetium 99 labeled HMPAO against SPECT scanning, that is actually confirmatory test in the diagnosis of brain death. There is a sign called as hollow skull phenomenon. The absence of isotope uptake indicates no brain perfusion, and that also supports the diagnosis of brain death. So these are the ancillary confirmatory tests. Now, how you are going to proceed? Identify the cause of coma, exclude the confounders, perform the brainstem reflex test, apnea test, confirmatory test, follow institutional protocol when informing the family, manage the patient if the patient is a potential organ donor. So maybe the examiner would be, if you are answering so confidently, they would be trying to get this from you. So try to also sometimes watch when you have to read between the lines. So if you are a honors candidate, which I know you all are the honors expected candidates or the distinction expected candidates. So the examiner wants to know that you are till now doing perfect. Now, what would be the next thing that you can consider or you can involve the the organ donation team at this point of time? Okay, because your ICU care doesn't end just by declaring the brain death. Maybe if your system supports, family agrees, everything goes in the perfect line, so maybe this patient is a potential organ donor. Now, step 6, how will you certify brainstem death? This is something very important. The protocol set up by respective governments. In India, this is THOTA, Transplantation of Human Organs Act 1994. Remember this act, remember the year. The examiner wants this like year name or the act name. This has clearly laid down to the guidelines for the declaration of brainstem death, and the detailed documentation has to be done in the form number 10. Remember this 10 number. Recently conducted IFCCM, that was a paid question. Now, this form clearly lays down the method of performing brainstem evaluation. Now, two sets of brain death examinations are mandated, done by two teams of doctors, and the second is typically done 6 hours after the first to declare brainstem death in adults. So, two sets, 6 hours apart. In neonates and pediatrics, this period of observation is usually longer and is left to the discretion of the doctors performing the brainstem evaluation. Now, step 7, inform and counsel the family. As soon as this is suspected that this patient is nearing brain death, the clinician should keep family members informed of his or her clinical status and manage as per the protocol, making sure to maintain him or her hemodynamically stable. This is not preemptively you are doing just for the organ donation. Rather, this is going on your mind as an intensivist who feels that this patient may be suitable for the organ donation, but it's not, or it's never the intended action by you just to promote organ donation. This is very clear, and the examiner may try to trap you also, that should you start discussing the organ donation part before you have declared the brain death? No, rather maybe another team, organ transplantation, organ donation team, they may initiate, but it's not your domain at all. Make it very clear. Now, as declaring brainstem death is a sensitive issue, a senior member of the team, ideally the primary consultant in presence with the intensivist, should counsel the next of kin, and once the clinical criteria for brainstem death have been confirmed, declare him or her dead. Maybe in the counseling or communication part, the examiner would be asking you, should you send your junior doctor to go and discuss about the brain death to this patient's relative? No. This is one case where, as the senior most member of the team, maybe the intensive care, maybe the neurology, maybe some other like the specialty, they should be involved for the discussion or breaking the bad news. It's never the junior most doctor, preferably no. The family then can be approached to request for organ donation as per the regulation of the law. And if the next of the kin declines to donate organs, then it is a good medical judgment to discontinue the mechanical ventilation, depending upon again the rules and regulation. Now, I'm trying to share with you, is everything okay with this short case? Anyone wants to post anything? Because I'm trying to only share the things that is actually expected in a short case. It cannot be theory. You are not expected to answer like 30 minutes there. Okay, but these are the basic things, important thing that is mandatory. Now, two more short cases I will be just be like making for your observation and understanding. One is winning failure from the ventilator. They may keep one of the patient who is a difficult winning in their ICU, and this is a favorite question, favorite case. I am making it a one pager only, just for your like a better understanding. Now you know how to answer. This is a 60-year-old male post sepsis with repeated spontaneous breathing trial failure. Now, how you are going to answer in the focused examination part? Why this patient is a difficult winning? Tachypnea during SPT, use of accessory muscles, weak cough. What is your interpretation? Most probably, this patient is having diaphragmatic dysfunction or ICU weakness or ICU acquired weakness. What are the immediate concerns you have? Fatigueness and respiratory muscle failure if I will be continuing with the SBT. What are your management plans? Optimize the nutrition, physiotherapy, consider ultrasound diaphragm assessment to know is there anything related to VIDD, gradual weaning with the PSP so that I can get some or other better performance maybe the days to come. What is your reassessment plan? When you are going to do reassessment? As I have told in the top 10 golden tips, it is always you should end with a reassessment. I would be monitoring the respiratory parameters and muscle strength daily. Clear? So this is in one page, in maybe 60 seconds, you can summarize your case. How you should present. If somebody asks me that, sir, you are now talking something, depending upon the examiner, maybe they will be asking me in the similar trend, then I would be answering. If they would be asking something or other, maybe I will not get the opportunity to explain my case confidently, maybe for 45 to 60 seconds. Now, how you should be summarizing your case? If I would be giving you this clinical case, so what would be your approach? Is there anyone who wants to share? Are they allowed to speak, Bhagyasri? No. I think just for the sake of
Yes, sir, we have
no.
allowed them to text.
Okay,
All are
okay, okay,
panelists only.
okay. Panelist only, but not the delegates, no, not the attendees. Okay, okay, no problem.
Yes, sir.
Okay,
They
no
do
problem.
have right permission to write their query. If anyone face any issue, let us know.
Okay, okay, no reach. So if anyone wants to present this case, then Navneet would be allowing you to speak because it's a practice also, like how you are actually presenting. It's not the theory class that we are actually doing it. Okay, no problem. I'm trying to explain maybe the next one that I would be sharing. You should be speaking. Now, this is a 60-year-old male recovering from sepsis with repeated spontaneous breathing trial failures. On focused examination during SBT, the patient develops tachypnea, uses accessory muscles, and has a weak cough. My interpretation is likely respiratory muscle weakness, possibly ICU acquired weakness or diaphragmatic dysfunction. My immediate concerns are respiratory fatigue and risk of extubation failure. My plan would be to optimize nutrition, ensure electrolyte correction, initiate aggressive physiotherapy, consider diaphragm ultrasound, and proceed with gradual winning using pressure support ventilation. These are the things I have mentioned in my this slide. My interpretation, my immediate concern, my plan on focused examination. So these are something ISU specific language. So that you should be using in your presentation or when you are answering. Clear? Now finally, the reassessment that I have ended with, always end with something that would be giving the idea that ICU is a dynamic place. So I would reassess respiratory parameters and muscle strength daily. Now I have also given you another short case just for the practice. Metabolic encephalopathy. Here I have written already, but in the examination it would be altered sensorium in the ICU. Just like the previous case, difficult weaning from the ventilator. Right. So you cannot say that metabolic encephalopathy, but yes, you will not get the cheat metabolic encephalopathy. You will get the idea from the the helps in the examination hall that this patient having altered sensorium in the ICU for last 5 days. Okay. Now, one line introduction. This is a 58-year-old diabetic patient in the ICU with acute onset altered sensorium. What is the focused examination finding? GCS E3, V3, M5. People is equal and reactive. No focal neurologic deficit. Now, what would be your interpretation? It is likely metabolic encephalopathy. Structural cause is less likely. There would be some CT head film you will be checking. There would be no obvious pathology, and also some other investigations you can check. They will not be hinting towards a structural cause. What are the immediate concern for you at this point of time? I would be maybe excluding hypoglycemia, electrolyte imbalance, sepsis associated encephalopathy, right? What are your management plan at this point of time? Check the glucose immediately, ABG, electrolytes, ammonia, because in metabolic encephalopathy, ammonia levels should be also measured. Review the sedatives and analgesics. That can also be one of the confounding factor for this patient to be in the altered sensorium in the ICU. I would be also treating the underlying cause at this point of time. What would be my reassessment plan? Neurologic reassessment after correcting the metabolic abnormalities. Clear? Now, I am now giving you again another the one slide how you should present. If you have been given this case, you have examined this patient, taken the history. Now the examiner comes to the examination site, like the bedside, and you have been asked to present your short case. So you should be starting in this way. This is a 58-year-old diabetic patient in the ICU with acute onset altered sensorium. On examination, the GCS is E3V3M5. Peoples are equal and reactive, and there are no focal neurologic deficit. My interpretation is metabolic or toxic encephalopathy with structural causes less likely at present. My immediate concerns are hypoglycemia, electrolyte imbalance, drug effect, and sepsis associated encephalopathy. My plan would be to immediately check capillary blood glucose followed by ABG, electrolyte, renal, and liver function, review sedatives and analgesics, and treat the underlying cause. I would be reassessing the neurologic status after correction of the metabolic abnormalities. I think now the idea, the concept with which I am trying to actually explain the short cases is very clear for anyone. Okay, so there is a universal 60-second short case template that I would be sharing in the group later on. So I think we can stop here for the short case, and give me a sec where I would be now sharing with you the organ donation, brain death, and other things. Any questions at this point of time? We can take a 1-minute pause here. Please post. Okay. So anything at this point of time? Should I be little bit slower, or is it okay for you all? Because I am the last speaker for this day. It's okay, no? Okay. Okay, so they will give us the history, or do we need to take from the patient? They may share with you a small one-liner or two-liner in the cheat, or they may like allow you to ask the nurse and also the bed side files. Okay, but don't expect that you will be given the whole permission to like find out everything, because this is a short case. So it would be like taking your time. Maybe rather in some of the centers, just to like finish it on time, they would be sharing with you a small paragraph where most of the things related to the short case would be there, and you are not expected to just like go through everything in the 5 minutes or 10 minutes or 15 minutes time they would be assigning to you. Which systems you examine, it would be depending on the the case. It cannot be like tell or I cannot presume. If it is CRRT, AKI and CRRT, they may ask or they may expect it would be more related to the AKI part, and the prime organ, that is kidney, urine output, renal function test, and the machine, which is the CRRT or the dialysis machine. Clear? Now, if it is a difficult winning, so as I have told, it would be more towards the respiratory system, the accessory muscles, ABC, and the ventilator. If it is like no COPD patient, not getting the CO2 in the range, respiratory acidosis, so they would be expecting you to discuss more towards like the respiratory part, CT scan, then the ABG and the BiPAP machine or NIB, or maybe there would be one which would be the ICD. Now, apnea test and consent. Now, this is something is little bit tricky. So, consent from the family, if you want to declare or you want to go ahead with the brain death declaration after explaining, definitely you should be expected to discuss about the apnea test or the whole process, what you are going to do. Because sometimes what will happen if the patient actually suffers cardiac arrest during the apnea test, maybe there would be false perception that you have tried to do some procedure which has resulted in the cardiac arrest, right? So it is always better to document it and mention it, that the consent has been taken, or you are proceeding with the brain death declaration, and the steps you can all mention. Now, what if they deny? It's a little bit tricky again. If they deny, that means they are not willing to go for brain death declaration. Many of our patients, we all continue, but we don't like to subject the patient for the proper 4-member team, like neurologist, primary consultant, then the medical administration. That means they are not in favor of declaring the patient brain death. So we have to honor their request. But yes, we can continue to discuss that in the subsequent counseling. Right? Yeah. So anything at this point of time? Okay, no. So let's start with the other table viva, because there are almost 80 slides. I want to be okay, perfect. Now, first one is the brain death and organ donation, which I think I have already touched upon most of the things. So I would be just showing you the slides, but the things are already discussed. The first one, I would be discussing brain death declaration and organ donation. Pay attention. This is really, really important. You will be expected to answer brain death in your critical care exit exam, whether it is DRNB, DM, IDCSM, IFCSM, EDIC, because this is right now linked with the organ donation or brain, like the different other advanced like DCD also. Hot topic, mark fetching. Examinees make mistakes. I would really suggest you to simulate in your units prior to exam. Case scenario, very standard case, 40-year, severe traumatic brain injury, GCS 3, E1, BT, M1, bilaterally dilated non-reactive pupils. CT scan, showing diffuse cerebral edema with effacement of basal cystons and transtentorial herniation. Classical. Now the patient remains deeply unresponsive 48 hours post-injury despite full supportive care. ICU team suspects brain death and initiates the formal assessment. Now please proceed. This would be the expected question. Already I have told about the examiner may ask at this point of time, what is the difference between coma, persistent vegetative state, and brain death? This is a classical question. Sometimes they would start with this one. So, brain death, we all know. This is irreversible cessation of all functions of the brain, entire brain, including brainstem, and it is legally recognized as death. Now, coma is a deep unconscious state where brainstem function may still be intact and there is potential for recovery. Very classical. We all know. We sometimes say in our patients, patient is in coma. That doesn't mean that this patient is brain dead. Okay. Now the third thing would be persistent vegetative state, PVS. This occurs when the brainstem functions remain intact, but there is no awareness or cognitive function. Patients may have the sleep-wake cycles, spontaneous movements, and or eye opening, unlike the brain dead patients. Clear? I think. Okay. So something I think we have to be very clear. Now, common mistake, confusing brainstem with brainstem death or brain death with coma or PVS, and sometimes like you have to get some extra marks by mentioning that it is a state of complete brainstem failure, while persistent vegetative state patients have preserved autonomic functions. Differentiation is crucial for the ethical and legal decision making. Now, what are the conditions must be met? Already I have mentioned. I'm just trying to show you that these would be the questions. Common mistake would be not mentioning that brain death cannot be declared in patients with a drug intoxication, severe metabolic acidosis, or hypothermia. Right? So something you have to go through repeatedly so that in the examination you should not be confused. Now, some of the smart answers. EEG or somatosensory evoked potentials may be useful in cases where drug toxicity or metabolic derangements are suspected. In that case, what will happen? If you will be doing EEG or somatosensory evoked potential, you will get some of the waves, not typical for the brain death. Okay. How you are going to confirm the brain death clinically? Already I have told you, but yes, these are the tests, brainstem reflexes. We have already discussed how you are going to perform it and what is the expected brain death finding that you should be remembering. Clear? Already discussed in the examination, you should be mentioning this. Common mistake, failing to mention that spinal reflexes like triple flexion may persist in the brain dead patients. Now, smart answers, brain death doesn't affect the spinal cord activity because this is brainstem death. This is not the spinal cord death. So some movements like the Lazarus sign may occur due to residual spinal function, but these are not the signs of the brain activity. Clear? What is apnea test and how it is performed? Again, I think I should not be going ahead with this, but yes, this is just to the common mistake. The examiner would try to confuse you, stopping the test if hypotension or hypoxia occurs and calling it positive. No, a failed test means the test is inconclusive, not positive. Clear? Now, smart answer, apnea test should be aborted if SpO2 is repeatedly falling below 85% or MAP less than 60. At this time, I should not be saying that yes, brainstem death cannot be declared or assessment cannot be happening or this patient is not fit for brain death declaration. No, an alternative confirmatory test should be used. Clear? Now, are confirmatory tests mandatory? The question can come from the examiner. Not always needed. If your clinical criteria are met, It is required when clinical tests are unreliable, like in drug intoxication or facial trauma affecting the reflex test. When you cannot do any of the brainstem reflex test, or you are like unable to conduct the apnea test because the patient is in severe ARDS. Now patient is like, no, the saturation is falling immediately to 75%. Despite your vasopressors, the blood pressure is not holding. So in those cases, you have to depend upon the confirmatory tests. Now, what are the common confirmatory tests to like include? Cerebral angiography, no cerebral blood flow; EEG, no brain activity; transcranial Doppler, absent diastolic or reversed flow. Now, what is the common mistake people say? That EEG is always required for the brainstem death diagnosis. No, it is only needed in special situations. Now, smart answer, different countries have variable protocols. UK doesn't mandate confirmatory test, while Japan requires additional tests before declaration. Now, final takeaways for the high marks, stepwise structured answers, definition, criteria, test, documentation, ethics, avoid the common mistakes and use global perspectives. Now, how do you approach the family for the brain death declaration and organ donation? This is a pet question because the brain death is just part. They would be expecting you to answer or be clear about the counseling to the family and the further organ donation. So step 6 would be the legal and ethical aspect. Discuss with empathy, use simple language, avoid pulling the plug, this type of phrase. Legal death declaration, time of death, they would be asking you, when will be the time of death? Is when the second assessment confirms brain death, not the ventilator disconnection time, right? When you are assessing and you are finding that this patient is not the the brain death is working, so that is the time, not ventilator is disconnected. Discuss the organ donation sensitively. If eligible, always involve transplant coordinators. Now, common mistake, we will stop life support now. No. Explain that brain death is legal death and no further treatment is possible. That means once they have given the consent, you have proceeded with the brain death declaration process. You have involved, you have created the team of doctors who will be checking, assessing, and 2 tests have been conducted, and you have already made the brain death declaration, and the time has been noted. Then you have to politely explain to the family or break the bad news. Now, smart answers. Many families are actually not knowing that organ donation is possible after brain death. Providing clear, respectful information can lead to meaningful discussions. What is the status in India? I have already told. THOTA 1994 was the first Transplantation Act passed, and its amendments were in 2014 and 2019. And this differs from so many other international protocols in the examiner requirements, number of assessments, and mandatory documentation, something that has to be different from country to country. In India, conformity tests are needed only if clinical criteria cannot be fully assessed. It is not mandatory. Clear? 4 doctors must independently certify brain death. ICU in charge, registered medical practitioners, neurologist or neurosurgeon if unavailable, intensivist with neurology training, treating physician, government appointed doctor for organ donation cases. Clear? Now, 2 independent brain death assessment must be done 6 hours apart. Time of death is time of second brain death confirmation. Form number 10 is the brain death certificate that must be filled under THOTA. Now, smart answer. Okay, 2 tests, 4 independent doctors. Ethical family considerations, you have to use all your words in a very polite and empathetic way. Now, this is something we have already explained. Okay, key differences. Again, I have summarized it. UK, US, other countries, India. Number of examiner here 4. In other places 1 to 2. Number of tests 2 tests 6 hours apart. Confirmatory test not mandatory. Time of death, second test declaration time. Legal framework 1994, 2014, 2019. And organ donation link, declaration separate from the donation. Right? Okay. Now, management of organ donor in ICU, that would be the second part. Now, I would be sharing with you a clinical vignette. A 35-year-old male with severe traumatic brain injury following a road traffic accident is admitted to the ICU. Despite all efforts, he meets the brain death criteria after 2 examinations have been performed 6 hours apart by 4 independent examiners as per THOTA 1994 guideline. The family has agreed to organ donation and the ICU team now needs to manage the donor to preserve the organ function. Now questions come. Why is ICU management of an organ donor is important? First, general principles of organ donor management. Brain death that leads to the progressive physiologic instability due to loss of the HPA axis and the brainstem control. So what happens? We as intensivists are responsible or trained to manage the optimization of the organ perfusion, preventing ischemic injury or further ischemic injury. This ensures maximum number of viable organs for the transplantation purpose, and this maintains hemodynamic stability, avoiding hypotension, hypoxia, or metabolic dysfunction. Clear? This should be the first 3 lines. If your examiner is asking why the intensive care is so important for organ donor after brain death. Okay, the first would be optimizing organ perfusion. As a result, we are ensuring maximum number of viable organs and we are also responsible to maintain the hemodynamic stability. Common mistake, brain death is same as cardiac death. No. After brain death also, the circulation is still ongoing. That means heart is pumping. So you cannot say this patient is having cardiac death. So the goal of ICU management in brain dead donors is to maintain multi-organ perfusion, optimizing transplantation outcomes or viability. Now, what are the common cardiovascular changes after brain death and how do you manage them? Hemodynamic manage, initially what happens, there would be catecholamine surge leading to first would be hypotension followed by profound vasodilatation and hypotension because of loss of the sympathetic tone. Due to the catecholamine storm, the patient will have arrhythmias and myocardial dysfunction. So these are the cardiac or cardiovascular changes after the brain death. Now how we are going to manage? Volume resuscitation, crystal load first, normal saline, ringers lactate. Vasopressors and ionotropes, for the hypotension start noradrenaline first line, then vasopressin. Now for cardiac dysfunction, consider dobutamine or milrinone. Your target of the map would be to more than equal to 65 to maintain the adequate organ perfusion. Now noradrenaline is preferred over dopamine because of better splanchnic perfusion and reduced arrhythmogenic risk. How do you optimize lung function in a brain dead organ donor? So what is the pulmonary management? Basically the whole idea is, do you know how you are going to maintain the lung status? Brain death leads to neurogenic pulmonary edema, atelectasis and ventilator associated pneumonia risk. Now, ventilation strategy would be lung protective ventilation, low tidal volume 6 to 8, PEEP 5 to 8, FiO2 less than equal to 40% to prevent oxygen toxicity, recruitment maneuvers to prevent the atelectasis, minimize barotrauma. You should avoid excessive PEEP. So this is at the basic pulmonary management, but in the examination, they would expect that you are mentioning these points. Common mistake, over oxygenating with FI to 100% leading to lung injury. So don't put blanket 100% for every organ brainstem death patient, a potential organ donor, right? And you should be trying to reduce or prevent ventilator induced lung injury. Now what are the what are the things that common endocrine disturbances? This is a pet question. Pulmonary, cardiovascular, then the endocrine. Endocrine and metabolic derangement happens because of this hypothalamic pituitary axis failure leads to hormonal deficiency. As a result, what happens? Diabetes insipidus, the mechanism is ADH deficiency leading to polyuria and hypernatremia. So these are the two things you should be remembering. Treatment, vasopressin, 1 unit IV bolus, then infusion at 0.5 to 2.4 unit per hour. Right. You can also go ahead with the nasal spray of the desmopressin, which is the vasopressin congener. Right. Now, the cortisol deficiency would be the second endocrine disturbance that can happen, and the mechanism is loss of the ACTH hormone. So, as a result, a adrenal insufficiency happens. The treatment would be IV hydrocortisone 100 milligram bolus, then 50 milligram Q6H. You can also go ahead with the high dose of steroid in these patients, 1 gram methylprednisolone. Now, thyroid dysfunction also is the third endocrine disturbance, T3, T4 deficiency. So some centers they use T3 replacement, that is IV liothyronine, if your myocardial dysfunction is severe. So this is one condition where you are actually giving thyroid hormone not for the thyroid related problem, rather it acts as the inotrope. So the cardiac contractility will be better if you are giving the thyroid supplementation. Now, common mistake, overcorrection of sodium too fast in the DI, right? And vasopressin corrects the DI while also improving the systemic perfusion by reducing vasodilatory shock. So it is a two, the benefits are actually two-edged. So you are actually helping the DI and also the vasodilatory shock. Now, the next question that the examiner may ask, why is temperature control is important in brain dead donors? Again, brain death abolishes thermoregulation causing hypothermia, and hypothermia reduces the oxygen delivery, and as a result what happens? It worsens the metabolic acidosis. The patient can go into DIC if your patient is continuously having severe hypothermic following brain death. Now the management has to be passive warming, active warming, and target temperature should be 36 to 37 degree. Ignoring temperature control leading to systemic dysfunction is a common mistake. So you need to go ahead with the active warming. What electrolyte imbalances occur in brain dead donors and how we are going to correct them? Common electrolyte disturbances, the examiner's pet question: hypernatremia, hypokalemia, hypocalcemia, and hypomagnesemia that can affect your cardiac function. Correct approach would be sodium correction, potassium correction, magnesium and calcium replacement to prevent arrhythmias. Overcorrecting again, sodium too fast would be leading to cerebral edema. So that is something we need to answer in the exam. When should organ retrieval be planned after brain death certification? Timing and logistics. Organs must be retrieved as soon as possible after certification to prevent ischemic damage. Now, organ donation is coordinated by the transplant team and National Organ and Tissue Transplant Organization in India. Right? So, this is something you need to remember. Now, you have to also, the common mistake in the heat of the moment, the candidate sometimes mention about that ICU team is responsible for organ retrieval logistics. No, the ICU team stabilizes the donor while the NOTO and the transplant team handle the retrieval. Form number 10, I have told what is the full form of NOTO, that you should be remembering, that oversees the organ allocation. Common mistake, family consent is not needed in India. No, explicit consent from the next of kin is mandatory for going ahead with the organ donation. Right? It is a strict legal framework under THOTA requiring 4 doctors and explicit family consent. Okay, so I would be now going ahead with the, just one second, breaking bad news, which is again something very important. At this point of time, any questions? Any questions at this point of time? Is it okay? Perfect. Okay. Now, breaking bad news, you have read in detail during your theory exam preparation, and we have also multiple times explained about this. So what I am going to do, I would be giving you a scenario and how you are going to break the bad news. A 45-year-old male with severe traumatic brain injury has been declared brain dead. You have to inform the family. The family is really hopeful and waiting outside to hear some good news from you. As you have entered now, you have assessed the patient, and now they are waiting in front of your counseling room. So, how we are going to break the bad news? Spikes protocol. The examiner loves this protocol. S for setting. I'm not going into detail. P for perception. I for invitation. K for knowledge. E for empathy and emotions. S for summary and support. Clear? I think I should not be going into detail. You have all been thorough in this. Second scenario, a 68-year-old female with metastatic cancer and multi-organ failure, right, is deteriorating despite full ICU support. You have to discuss with her daughter to transition to the comfort care. Now, these are the scenarios the examiner would be having, and they may put it during the long case, during the short case, during grand viva also. Okay, so be ready. Now the structured approach, here I have used nurse protocol for empathy. N for name the emotion. I can see that you are very worried. You understand the emotion. Anyone in your position would feel the same. R for respect. You have been making the best decisions for your loved one. S, support. We will ensure she is comfortable and pain-free. And E, explore options. We have reached a point where aggressive ICU care is causing suffering rather than helping. Would you like to discuss a more dignified approach with comfort-focused care? So this is something you are trying to mold the family to opt for the transition care, transition to the comfort care. Clear? Now, next scenario is a 55-year-old male with severe COPD has failed multiple extubation attempts. Now you have to explain the need for prolonged ventilatory support via tracheostomy. How we are going to explain to the family? Explain the situation in simple terms. Your father has been on the ventilator for several days. His lungs are weak, and despite trying to remove the breathing tube, you should not be using ET tube for a layperson. They don't understand this. Breathing tube, he cannot breathe well on his own. Now, when you are putting the tracheostomy option in front of them, give a rationale for the tracheostomy. A tracheostomy is a safer, more comfortable way to provide long-term breathing support. It reduces risk of lung infections and allows him to be more awake and comfortable. So this is something as the second point. Now you should be acknowledging some of the concerns from the family. I understand this is a big decision. We will support you with more information and help you understand what to expect. Now, last point would be discuss the prognosis and next step. Now, this doesn't mean he will always need a ventilator. It gives him the best chance for recovery while preventing complications. Now, the other scenario, the next one, a 40-year-old man admitted with septic shock had a sudden cardiac arrest despite full resuscitation. You have to inform the family about his death. How we are going to break the bad news. So the examiners, again, one of the favorite clinical case scenario. Now structured approach here, ABCDE framework. A for awareness. I have some very difficult news to share. B, brief explanation. Despite our best efforts, his heart stopped suddenly and he did not respond to our continuous resuscitation for last 45 minutes, 30 minutes, 15 minutes, whatever. Now, confirm death clearly. Don't move here and there and beat around the bush, because you have to break the bad news as you are the attending at that point of time. So I am very sorry, but he has passed away. Make the statement very clear. Now, fourth point, demonstrate empathy and allow silence. Once you mentioned about that he has passed away, you should be giving a pause for maybe 5 seconds, 10 seconds. Allow them to process this information and then say, I cannot imagine how hard this is for you. and explain what happens next. That is E. Discuss the post-mortem formalities if the patient is a medical legal case. Support services. Offer time to see the body. Invite the family to be at the bedside, the deathbed, something like that. Then another scenario. A 65-year-old male was intubated and needed a central venous catheter. After the procedure, he developed a pneumothorax requiring chest tube insertion. Now you must inform the family that there has been a complication following a procedure. Now let's take the help of Spike's protocol. Setting again, perception. You should, before I explain, can you tell me what you understand about today's procedure? Something you can start with. Invitation. Would you like me to explain everything in detail? Now, K, explain clearly. This is again, the examiner would try to lead you. Should you hide the thing? Should you keep it within you? You are not mentioning this to the family because the family will be angry, or they would be losing their confidence on you. No, you have to be explaining clearly that during a central line insertion, a rare but known complication, this word is very important. Rare, percentage may be low, but it's a known complication called pneumothorax, that is air leakage in the lung, occurred. This happens in about 1 to 2% of cases. Despite all precautions, we identified it immediately and placed a chest tube to remove the air, and he is stable now. Clear? Now, I understand this is distressing. We took immediate steps and he is being monitored closely. Finally, summary and support. I am open, or I am offering you to answer more questions, providing the family assurance that all necessary steps have been taken or being taken to prevent further complications are being there. Okay, I think these are some of the clinical scenarios you are all right now well versed with. Maybe this is something about a rude family, something like they are accusing you of negligence. So this is a concept called as Lassie method for conflict resolution. This is again, the examiner may ask you how you are going to proceed with the conflict resolution. So you listen in front of the family, angry, and they are threatening the staff. Allow them to express their emotions without interruption. Stay calm and acknowledge their pain. Do not argue or become defensive. And you can use the words like, I can see how devastated and frustrated you are. This is a heartbreaking moment. You should acknowledge the feelings. I can only imagine how hard this is for you. You trusted us with his care, and I understand that this outcome is very difficult. Now, separate facts from emotions. Explain in simple words. Despite all efforts, his infection was too serious and his body could not recover. Our team worked tirelessly, but unfortunately, some infections become too overwhelming. Maybe some MDRO organisms you can mention about. Now, if aggression escalates, the examiner would be now at this point of time will say that you are explaining now somebody is trying to beat you. So you have to call the security or staff for de-escalation. Keep a safe distance, but remain professional. Don't lose your temper. Okay. Inform about your next step. Offer postmortem or case review if the family insists on explanations. And end with the support. Provide bereavement support. And maybe you can end with, we'll give you time to process this, and I am here to answer any questions you may have. Right. So I think with this, we can conclude with our breaking bad news. Now I am going ahead with the clinical audit part. Okay, this is again one of the important the exam question. Any questions at this point of time? Am I going to the speedy, or I should be cut short my presentation? Okay, good. So you are okay with the presentation? So because these are something which should be repeatedly you should be listening to, so that the confidence in your answer should be there. and you should clear what would be the words, the statements that you should be using to get full marks from the examiner. Okay. Now, clinical audit, you will be getting definitely in your exam in one of the tables. Okay. Now, this would be the scenario. The examiner would not directly ask you what is clinical audit in your ICU. Rather, they would be giving you a scenario. You are working as a senior ICU register in a tertiary care hospital. The ICU team has noticed a high mortality rate in patients with septic shock. Now, the department head has asked you to conduct a clinical audit on adherence to the surviving sepsis campaign bundle within first 6 hours of the sepsis diagnosis. Clear? So this is the question would be leading you the clinical audit in critical care. Now, structured answers for the audit in the exam, the title of the audit, they would be expecting that how you are going to name the title. Compliance with the 1 hour and 6 hour sepsis bundle in ICU, a clinical audit. Something like this. Now the background, why you are like the hospital head, the department head has chosen this topic, because sepsis is a leading cause of ICU mortality, and SSC 2021 guideline or 2024 guideline recommend early recognition and prompt management, and studies that have shown that adherence to the sepsis bundles reduces mortality significantly. So that's why we have chosen this as our audit topic. So audit topics cannot be like whatever problem you face, you should be start doing an audit. Okay. Now audit aim for this title would be to assess the adherence to the sepsis bundle elements in ICU patients diagnosed with sepsis or septic shock. And as a result of this audit, we are trying to identify gaps and implement quality improvement strategies. Right. Now, there are certain audit measures that we will be doing. Compare the ICU compliance to the surviving sepsis campaign 2021 bundle. So we would be comparing the standard guideline and our observation in our hospital. So within 1 hour, we will be following with the same surviving sepsis campaign guideline protocol. Within 1 hour, measure the lactate level, obtain blood cultures before antibiotics, and administer broad spectrum antibiotics. Start IV fluids 30 ml per kilogram crystalloid for hypotension or lactate more than 4 millimole per liter. Now within 6 hours, apply vasopressors, reassess the volume status and tissue perfusion. Repeat the lactate measurement if your initial lactate is more than 2 millimole. Now audit methodology in this particular audit would be retrospective or prospective observational study. Now, sorry. Inclusion criteria, all ICU patients diagnosed with sepsis and septic shock as per the sepsis 3 definition. Exclusion criteria, patients who received treatment before ICU admission will not be admitting, because we don't know that what was the lactate, how they have received the crystalloids. Sample size, maybe for this I would be targeting 30 to 50 patients over 3 months. Data collection would be by reviewing the ICU case records, electronic medical records, and the sepsis order set, maybe the antibiotic prescriptions. Results and key finding, percentage compliance with each bundle element. That would be our result. And we will be trying to identify also common gaps like delayed antibiotic administration, under use of lactate monitoring, something that we can find. And then we will be interpreting that yes, maybe we will be sending ABGs immediately to know the lactate so that we can start the fluid resuscitation in time. Now, what are the action plan for quality improvement? At the end of the audit, we can implement sepsis checklist at ICU admission with a one pager. Conduct the regular sepsis awareness training for the ICU nurses and residents. Maybe I can introduce early warning scores or rapid response teams to identify the sepsis early in the wards or in the emergency department. And the most important thing the examiner would be expecting, re-audit after 6 months to assess the improvement. So in conclusion, a well-conducted clinical audit helps standardize sepsis management and improve patient outcome. Clear? So this is something in the clinical audit. Now, some of the Viva questions they may ask you: how do you choose an audit topic in the ICU? Is it everything that is coming in your mind, or somebody is saying no? Identify the high impact clinical areas affecting patient outcome. Okay, sepsis is one of that. Focus on evidence-based guidelines where the standard guidelines are actually having concrete information. Surviving sepsis campaign, KDIGO AKI guideline. Look at the frequent errors or variability in the ICU practice and choose a topic where quality improvement is feasible. It's not that you are hitting something on the wall where you are unable or there is no no expectation of any improvement also. Now, what are the key steps in conducting an audit? Identify the audit topic, define the objectives, set audit standards. In our case, last the audit question, it was surviving sepsis campaign guideline. Collect the data, retrospective or prospective, from EMR, from the patient's record, from the antibiotic, the order prescriptions. Analyze compliance with the standards, identify gaps and propose intervention, and implement changes and conduct a re-audit for the improvement. How do we ensure that audit findings lead to clinical improvement? You have to share the results with the ICU team and hospital administration, implement targeted interventions, training, checklist, protocol revisions, monitor compliance and feedback via regular follow-ups, conduct a re-audit after 3 to 6 months to measure improvements. Now, what are the challenges that you might face in conducting an ICU audit? There are challenges definitely, and that's why conducting an audit is not so easy. Inconsistent documentation in patient's record, low adherence to the protocols due to workload or knowledge gaps, lack of institutional support or resistance to change. It's not easy to give fluid at the right time constraints in a busy ICU environment for the ICU nurse or the doctor, and the data collection bias if your criteria are not well defined. So you are collecting the data, but they are not the good data. Okay. Now I will be just going with another clinical audit scenario. The examiner may ask you. You are a senior ICU registrar in a tertiary hospital. During daily round, you notice variability in prescribing stress ulcer prophylaxis for critically ill patients. Now, the ICU head has asked you to conduct a clinical audit on adherence to the SUP guideline. How you are going to do it? First, you have to prepare a title of the audit. And here the title would be Compliance with the Stress Ulcer Prophylaxis in ICU. Are we following the guideline? Clear? Background and rationale. Again, it would be easy for us why we are doing this type of study. Critical ill patients are at risk of stress related mucosal damage and GI bleeding. Now, if you are indiscriminating using the SUP, it increases the risk of BAP or CTIF. And current guidelines as per various standard societies, ESICM, ASHP, surviving sepsis, they recommend SUP only for high risk patients. Now, if I am going to do this audit, it aims to assess adherence to the guideline based SUP used in my ICU patients. Now, my aim would be to evaluate the compliance with the evidence based criteria for initiating and discontinuing the SUP in ICU. And I would be also trying to identify overuse or underuse of SUP and improve the prescribing practices. Now, the audit measures again. What are the patients? Compare the ICU practice with standard guidelines. SUP should be prescribed only if more than equal to one high risk criteria is met, like mechanical ventilation more than 48 hours, coagulopathy, history of GI bleeding. Now, somebody can say history of GI bleeding within 1 year, severe burns, more than 35% of body surface area, or major trauma, or high dose steroid. Right, appropriate choice of agent as per guideline, whether it is PPI or H2 blocker, and timely discontinuation when your risk factors resolved. Methodology again, retro or prospective. Inclusion criteria: adult patients admitted more than 48 hours, on mechanical ventilation or at risk of stress ulcer. Exclusion criteria, patients already on PPI or H2 blockers for chronic indications. Data collection would be through the electronic records and prescription charts, and we have to compare the prescribing practices with guideline recommendations. Results and findings. Yes, we will try to get the percentage of patients who received the SUP appropriately. Again, we also will get inappropriate prescribing given without risk factors, delayed discontinuation rates leading to prolonged therapy. What are the quality improvement measures action plan? We would be implementing ICU SUP checklist to ensure appropriate initiation or discontinuation have been followed up. Educate the residents and ICU nurses on guideline based prescribing. Introduce electronic alerts in the EMR for discontinuing unnecessary SUP. Maybe every 7 days there would be an alert coming in the EMR. Okay. And re-audit after 6 months. Always end with the re-audit. Conclusion, standardized SUP use improves the patient safety and reduces unnecessary medication burden. Regular audits help optimize the ICU prescribing practices. Now, one more thing have been like I am trying to now explain to you root cause analysis. This is a favorite question. I think in the theory also many people have got this question in the FAT exam also, some or other exams also. So I have kept it for the Viva also. Always start with a strong statement. If somebody is asking what is root cause analysis? Root cause analysis is a structured, systematic process used to identify underlying system level causes of adverse events rather than individual blame. You are not here trying to blame any individual person, rather just to trying to find out at the systemic level. A key purpose in the ICU to prevent the recurrence, improve the patient safety, and strengthen the systems and processes. Now, examiner keyword, they would be expecting you to mention systems approach, not person approach. Clear? When is RCA indicated in critical care? The next question somebody can ask, why you want to do root cause analysis in your ICU? RCA is performed after sentinel events, like death has happened, permanent harm has happened, like the patient has actually fallen from the bed, there has been some head injury, and after that the patient has never waken up, something like that. Unexpected ICU mortality. You never expected this patient will be dying, but yes, something has happened. Wrong drug, dose, route, delayed intubation or delayed RRT. Antibiotics have been given in a very late phase. Equipments or alarm failure that has caused permanent damage. Blood transfusion reaction leading to trally or something, and the patient has never woken up, or the patient has been intubated for long days. And healthcare associated infection outbreaks. Infection have actually caused so much of damage. So exam tip, RCA is never for routine errors, but for significant harm or near misses with high learning value. Where if you are doing RCA, it will definitely help the practitioners or the present and future, the people who would be coming to the ICU in a better way. Right? Now, principles of RCA, again, exam favorite. They would be asking you non-punitive and blame-free. It is not to blame. Focus on the processes, not people. Multidisciplinary involvement, evidence-based analysis, and action-oriented outcomes. RCA assumes that humans err, but systems should prevent harm. So it's not like no individual person who is responsible, or we are doing some RCA to blame or punish that person. Rather, the system should prevent the harm in the system, the system. Now, RCA team composition, who will do it? ICU lead or patient safety officer in your ICU or in your hospital, treating consultant, non-defensive role, ICU nurse or RRT nurse, pharmacist if it is drug related, biomedical engineer if it is equipment related, quality or infection control team. Very basic team composition. So examiner expects that here you are actually recognizing interdisciplinary learning, not hierarchy. That senior, then the junior, then the middle one. No, It should be interdisciplinary. Now, how we are going to do the RCA? You have to identify the event and notify it. Data collection from the case records, charts, monitor the data, and interviews. Event timeline reconstruction. What has happened, how it has happened, identify the contributing factors, root cause identification, you just try to reach to the root cause, and action plan and monitoring. So mnemonic should be the identification ID, data, timeline, cause, and fix. Okay. Tools used in RCA, something the examiner, if you are answering till now, they would be expecting that you should be mentioning about some of the tools. Common tools, the first one is fishbone diagram. Again, a very favorite question for the examiners. Fishbone or Ishikawa diagram. 5 whys technique, flowchart or timeline mapping, Swiss cheese model. So you just remember the names. I will try to explain one of these tool out of these 5 or 4. Now the domains in the fishbone, this one I am trying to explain to you. Human factors, equipment factors, environmental factors, policies and protocol, communication, and patient factors. Now the examiner may ask you what is fishbone diagram or Ishikawa diagram. Fishbone or Ishikawa diagram is a cause and effect tool used in the root cause analysis to systematically identify all possible contributing factors to an adverse event. Okay, so cause and effect tool. What are the main components? The components are actually the bones in the fish bone. Okay, people, I have already told, human factors, methods, protocols, SOP, machines, equipment, materials, drugs, fluids, environment, ICU setup, workload, and management or policy. So you can remember 6M in the fishbone: man, method, machine, material, milieu, and management. Remember this. Examiner may ask you. If you are answering this fishbone, they would be very happy. Now they will be expecting you to give one ICU example of root cause analysis. Now you are getting the problem of delay in the antibiotics in septic shock. Now people would be junior doctors delay. Method, there is no sepsis protocol in your ICU. Machine, delay in the IV access. Material, antibiotics not stocked in your ICU. Environment, busy ICU, they don't have time. Management, no escalation policy. Nobody has actually escalated this to the higher authority. So the root cause here is the system failure, not the individual person negligence. Clear? Now, another one, septic shock patient, delayed CRRT, cardiac arrest. Okay, this is the the event that you want to go for RCA. RCA finding was no CRRT machine available at night, delay in the nephrology escalation, nurses not trained for emergency CRRT, no routine escalation protocol. Now the root cause is doctor delay, no, it is the system failure in availability of the CRRT machine, training and escalation. Now, some of the things examiner may ask you: corrective and preventive action. What is kappa? Okay, actions must be specific, measurable, achievable, and time bound. So the exam tip would be, you should not be ending with a be careful next time. No, this is not the kappa finding. This is something very you can just have a unprofessional way of ending this type of root cause analysis. Now the example for this, if we want to do a kappa of our the CRRT machine failure or the patient died because of lack of you have not started CRRT, so it should be kappa would be 24/7 CRRT availability policy should be there in your ICU or hospital. ICU based CRRT checklist should be there. Nurse credential program has to be there, and mandatory escalation pathway. These are the things that you should be doing. Now, monitoring and effectiveness, audit compliance, track repeat events. You should be definitely tracking if something happened again. Definitely, this is not accepted. Monitor the key performance indicators like time to antibiotics, time to RRT, and feedback the loop to the staff. So RCA without follow-up is only documentation, not safety. Clear? Now, how to answer in the Viva? If examiner asks, how will you do RCA in your ICU? So you can always say, sir or ma'am, RCA is a structured, non-punitive system-based analysis performed after a sentinel event. We form a multidisciplinary team, reconstruct the timeline, identify contributing factors using tools like Fishbone and 5 whys, determine the root causes, and implement corrective and preventive actions with outcome monitoring. Now, you should close with the goal is patient safety and system improvement, not blame game. If you are answering this, you are expected to get 10 out of 10 in that table. Now, there is a favorite question again. The examiner may ask you, because I have completed clinical audit first and then RCA. So the examiner may ask you to just know the in-depth understanding of clinical audit versus RCA. Is there any difference, doctor, between clinical audit versus RCA? Anyone who wants to post? Because this is almost, we are reaching to the end of our presentation. I want to know how many people are with me. Clinical audit versus RCA. You can post in the chat box. Yeah. RCA is after Sentinel event. Okay. Anyone? Clinical audit single level solution, RCA multi-level. Yes. Okay. 3 differences. Audit already a guideline is there. Okay. Good. Okay. So we'll be now going one by one. The purpose of clinical audit and RCA. Purpose of clinical audit is to evaluating routine clinical practice against predefined standards to improve quality of care. Now, RCA investigates why a specific adverse event or near miss occurred to prevent the reoccurrence. Maybe there would not be a predefined standard. Now, the second one would be trigger. Clinical audit, planned, ongoing, and proactive quality improvement activity. But RCA is reactive, initiated after a sentinel event or serious harm. That already many of you have answered. Focus. Third one is the focus. Clinical audit focuses on compliance with the standards and performance gaps. RCA focuses on more of system failure and contributing factors, not individual blame. Now, in one line, audit asks, are we doing the right thing? And RCA asks, why did it go wrong? As simple as that. Okay. So maybe with this, we are okay and over with our today's presentation. These are the things that have been assigned to me, and happy to let you know if you want to have some information. And just for your understanding, we have our 3 days more to go with our all the agenda that we have shared. But there is one thing I want to share with you. We are coming up with an on-site, again, practical mock exam practice with simulation, with again table viva. Just for your just today only I am releasing this information, because before we were Bhavesh, don't worry, we will be sharing with you the recorded video till the date of your exam. Okay, so don't worry, you can watch multiple times. So what I was just trying to say you that we are coming up with on site our much appreciated course on January 10th and 11th, which is Saturday and Sunday. And this time it is in Mumbai, Fortis Hospital, Vasi. So the Mumbai people would be definitely happier, and the other people, they can come to Mumbai, because this would be something very interesting. You will have the exam type feeling, and something which you have never experienced, because now for next 20 days or so after we finish our online, you can pretty well go through these recorded videos multiple times, and on the date of this on-site course. So you can attend those 2 days, and you will be getting the difference, and the confidence would be something I don't know how you would be getting it. You can smash the examiners with your answers. So I am just sharing with you the details. Just hold on. The flyer is with me, and if somebody is interested, they can enroll us, and we'll also give some a good discount if somebody who has joined in our course and they want to also attend the on-site course. And it is very nominal only, because we have never tried to get the registration fees higher. Okay, so just I will be sharing with you the just 1 second. So this is all we have done, because so many people have actually requested that we should be also having something which would be very helpful for the examinees, just to get the exam vibe. Because whatever right now we are doing, it is just like we are doing it to cover up the course, but how you are actually performing. So in that 2 days, we will be showing you how the examinee and examiner should address. And we from the faculty team, we would be acting as the examiner and examinee. That is again a very novel way of like no doing the role play. And this is the Fortis Hospital Vasi, and we are conducting this there for 2 days, January 10th and 11th. And you will be happy to know some of the very reputed examiners, Dr. Jiggy Divatia sir, Dr. Rahul Pandit sir, and Dr. Asit Hegde. They have been invited to be the examiners, to take some or other the place where they can share with you how you should be answering, what is the expectation from the examinees. And there have been faculties from all over India, from Bangalore, from Mumbai, and we have also some of the toppers from the last time DRNB, who have been part of our course, and they have also agreed to be the examiner and examinee role play, so that it would be a practical experience. And this would be a 2 days, 10th January Saturday. And this is something I would be sharing with you. You can go through everything again in person. So you can go through, we'll be sharing with you all the details. All the table vivas would be shown to you, and you will be getting the candidate request session also like this. And the second day it would be long case mock presentation, short case mock presentation, and again 6 to 8 candidates will be in a group, where expert examiners would be assessing and explaining how to answer it confidently. And then there would be also individual assessment of the candidate, icebreaker session, where the question should be like cases, stations, communication, and some or other grand viva. So everything you will be finishing in a limited time, just like in the real exam. You are entering, you are completing one by one by one by one, and just coming out of the hall, something like that. Okay, so I think that would be really helpful. And believe me, we are trying our best so that you will not be again uh, going with the exam if you are not succeeded this time. So we are making no stones unturned for making your journey smoother and successful. Anything at this point of time? If you want to ask or post anything, I would be definitely happy to help you. Yeah, so don't worry, we will be sharing the details today only. And please contact our team would be helping you for the registration. So people have already started booking it. I have never posted before, because it would have caused confusion. So now, as we have already started our online course, so we are posting it. Okay, thank you very much. And tomorrow please join on time and start going through the agenda very confidently. We have tried to cover everything, so please share your feedback in the group, and please share this information with all of your groups, so that people can be benefited from this ongoing online course also, and also on-site mock exam preparation. Okay. Anybody who has missed also today also not registered, if they are interested, they can join tomorrow also. They can register. So it is not ended, and anyway recorded videos will be available to them. Okay. Thank you very much. Good night. Take care. Best wishes. Thanks, Navneet and Bhagyasri.